Okay, everyone, to my fellow board members, sorry to not be there with you in person. A last minute issue came up for me, and I just want to thank Sandra, Dr. Hernandez, for ably stepping in, and I will help run the first part of the meeting, and then before leaving, hand it off to Sandra to finish us off. And I think with that, Elizabeth, unless any other reason not to, let's jump in and call the meeting to order by taking roll.
Good morning. Secretary Dr. Mark Galley.
Present.
Dr. David Carlisle.
Present.
Dr. Sandra Hernandez.
Present.
Richard Koenig.
Present.
Ian Lewis.
Present.
Elizabeth Mitchell. Dr. Richard Pan. Don Molds. 5 present, 3 absent.
Okay. Thank you for that, and welcome to our June board meeting. As I turn it over to Elizabeth for our executive updates and sort of run through the meeting, I do just want to say how happy I am that we have a final budget and that the work since the May revise has been terrific to restore many of the areas that we were looking and hoping to have restored, that the opportunity with a bit more time and focus by both the legislative teams, the legislature teams and the administration teams to bring so much of the values of what our agency at HHS and this administration stands for and protecting those things was terrific. Obviously, there were some things that we had hoped to do that because of the budget weren't able to, but overall, very pleased with where we landed and just very grateful to everyone in the room there that helped us get to this place as we look forward to continuing the important work that we've had the privilege to do over the last 5.5 years as part of this administration. So with that, I'll turn it to you, Elizabeth, to go through our agenda.
Thank you very much, and good morning, everyone. So we have our agenda up, and we're looking forward to continuing the great progress that we're making on all of our initiatives under Margaretta Brandt's branch around value-based systems. And so we're excited to continue the discussion and hopefully take action on the alternative payment model standards. So we will be going a little bit out of order and starting with the informational item of 5B, again, where Margaretta will provide the update on the draft APMs. Then we will move to action item 4A, which is a vote to establish the APM model standards and adoption goals. The statute does require the board to approve the APM standards and adoption goals by July 1st, 2024. So if we do it today, we're right on time. From there, we'll move to 2 cost-reducing strategy presentations. Informational item 5A, the first from Blue Shield of California, followed by Adventist Health, and from there the agenda will proceed as written. In terms of executive updates, I'm excited to share that late last week we announced that CalRx branded naloxone nasal spray is now available for free to eligible organizations through the state and to certain organizations for $24 per twin pack through a contract that we have with Amneal Pharmaceuticals. So nothing like having the show and tell. So this is our first CalRx branded product. We're very proud of the progress and the leadership that got us to this point. So this is our first CalRx branded product. This is a more than 40% reduction from the $41 price that California has been paying for this product. So our partnership with Amneal to provide naloxone at this lower price is already benefiting Californians. In May, the state purchased 24,000 units for the DHCS naloxone distribution project, which is more than $400,000 in savings. So folks know that the opioid crisis continues to be a huge public health challenge with thousands of lives lost each year due to overdoses. So we're really working hard to get this critical tool in people's hands. We'd like to say, you know, I think obviously emergency responders have it, more and more schools have it, but we just think everywhere that has a first aid kit should have naloxone. So California businesses and entities seeking to purchase Calorex nasal spray for this $24 twin pack price can do so by visiting the Calorex website at calorex.ca.gov. Eligible entities can obtain the over-the-counter naloxone for free through the distribution project, and we're exploring the option for individuals to buy the product. And if this becomes an option, more information will be available. And my other update is about two staffing changes at HCI. We're really excited that HCI has 2 new clinical positions that we have filled. So we are hiring our first chief medical officer in our history, a chief medical officer and deputy director for clinical innovation. And then separately, we've also just hired, and she started on Monday, a chief medical officer. So I'll start with our new chief medical officer, Dr. Lemone Tefera. Dr. Tefera, who goes by Tef, has been a health policy advisor at CalPERS, so we owe a thanks to Don, where he has leveraged his years of experience as a clinician and health policy expert to lead improvements to members' health care and promote high quality and equitable access. Before coming to California, Dr. Tefera served as a Senate Health Policy Fellow and in the federal government as a policy advisor for CMS. He has his MD from the USC School of Medicine and a master's from the London School of Economics. And I can tell you from my conversations with him, he's very passionate about the affordability work that we are doing. He is a practicing emergency medicine physician with over 25 years of experience in community and academic hospitals, has held multiple faculty appointments, and has worked extensively overseas, including volunteering with Doctors Without Borders. So we're very excited to have Dr. Tefera provide his clinical and policy expertise to the work of OCA, Calorex, and other programs across the department. And then I'm also pleased to share that we've hired Dr. Helen Lee as OCA and HCI's new chief pharmacy officer to help us with Calorex and pharmacy costs and related work. So she has 19 years of experience, including with clinical trials, drug development, retail and hospital pharmacy, ambulatory care. Dr. Lee completed she has degrees from UCLA, from the Massachusetts College of Pharmacy, and her MBA from the University of Laverne. She's a CHCF Healthcare Leadership Fellow. So CHCF, as Sandra and I were talking earlier, has developed a wonderful cadre of leaders. She's served on numerous pharmacy-related committees, including for DHCS, and is also a California Health Corps disaster healthcare volunteer. So 2 really incredible professionals that we're very excited to join the team. So with that, I will turn it over to Vishal.
Thank you, Director Landsberg. I'd like to provide an update to the board and the public about our work plan for the upcoming quarters and topics beyond 2024. So for this slide, which shows Q2, Director Landsberg has already provided the agenda for today, so we could actually proceed with the next slide. As we previously announced at last month's meeting, we won't be having a meeting in July. That's canceled. And in August, we'll be having our first meeting outside of Sacramento, held in Monterey. That agenda will likely include an agenda item to approve the primary care spending benchmark. There is no statutory deadline for that activity, but ideally, if we were to get approval in either August or September, that would help with the data collection regulations process. The agenda would also potentially include the appointment of an advisory committee member with a rural health hospital perspective. So as a reminder, we do have a vacancy for that position, and the subcommittee will be reconvening this summer to review the submissions we've received. In that meeting, we'll also talk about regional variation in healthcare costs. We'll present research and data and studies, and then do a particular focus on Monterey as a high cost outlier, and do a case study on kind of some of the factors that have led it to be a high cost outlier. In September, if the board does not act on the primary care spending benchmark, we'll continue discussions about that. We'll also provide updates on total healthcare expenditure data collection. As a reminder, the first set of data for 2022 and 2023 for the baseline report is due in September, September 1st. So we'll be providing a status update. And then, as you may recall, we discussed some work that we were launching to better measure hospital spending that we discussed with the board and public in January. In September, we'll be providing a status update on progress made. And then we'll also be providing another update on the healthcare payments data program. So we had Deputy Director Mike Valley, who leads the Office of Information Services. He's presented to the board before. He'll be returning to provide updates on the latest with the HPD. I also wanted to alert the board and the public that we are rescheduling the September Advisory Committee to October. And then I'll move on to the next slide. In October, we'll cancel the October board meeting. At the October Advisory Committee, the topics we plan to discuss include those listed here. We're essentially providing both the October Advisory Committee and the November board meeting have some overlap in the topics we'll be presenting. So the key ones are potential updates to the data submission guide to include data for APM arrangements and primary care spending, updates on hospital spending measurement, and then behavioral health is a topic that we haven't discussed in depth. We'll be providing some updates on progress in defining behavioral health spending. We'll also discuss the quality and equity measure set proposal that OCA wants to put forward. An update on data collection related to workforce stability, and then an update on the status of the CMIR regulations revisions. In November, we'll provide the board with, as I mentioned before, similar topics that the October Advisory Committee has discussed. And then this was always the case. We had not scheduled a meeting for December. And then turning to future topics on the next slide. Under the total healthcare expenditure and spending target topics, we'll be providing updates on the data collection process. We'll have an introductory discussion on administrative costs and profits of health plans. We'll discuss our approach for public reporting of spending in the baseline report and gather feedback from the board and the public. And we'll continue to have discussions about progressive enforcement approaches. In the promoting high value category, we'll give updates on APM and primary care spending data collection processes, as well as any progress we made on behavioral health. And then under assessing market consolidation, we'll continue to provide updates on notices received, transactions receiving a waiver, or warranting a CMIR, and the timing of the review process, or the timing of OCA's review of notices and time taken to do a CMIR. So this is a good segue to the next slide, where I'll provide an update on the implementation of the CMIR program. So we have a separate inbox for questions related to the program, CMIR at hchi.ca.gov. And then to date, staff have received about 50 inquiries from potential submitters and members of the public. Since January 1st of this year, we've begun receiving notices for transactions. We've had over 125 unique registrations with 3 submitted for review. So in this table, these are the three that we've received. OCA determined a CMIR was not necessary for the first submitter, Santa Monica Rehabilitation Center, which is a skilled nursing facility that was changing operators after expiration of their lease. That review was completed in 24 working days from the date the submission was deemed complete. The second and third transactions involve LabCorp Holdings. The first one is about LabCorp's acquisition of Invitae's genetic testing and clinical laboratory for new subsidiary, LabCorp Genetics. This was reviewed on an expedited basis due to Invitae's bankruptcy. That transaction was waived 11 days after the submissions of both parties were deemed complete. OCA is separately awaiting additional information in LabCorp's acquisition of BioReference's laboratory testing business, which focuses on clinical diagnostics and reproductive and women's health. The 45 and 60-day clocks will not begin until the submission is deemed complete. Once submissions are deemed complete, a notice is posted on our website. And then next, I want to highlight a few areas from Oregon's recently published annual report. This report presents healthcare spending from 2021 to 2022. Some highlights include per capita spending growing 3.6%, slightly above Oregon's target of 3.4%. And this is the way that Oregon presents their reports when they remove net cost of private health insurance, which is equivalent to OCA's measure of health plan administrative costs and profits. They focus on essentially the total medical expense component for the three markets shown. So all markets came in below the target, and the excess growth was mostly in the admin costs and profits and other categories. And then the next slide shows Oregon's total medical expenses by market and service category. Their TME target grew, statewide TME grew 1.5%. And you'll see this was mostly driven by high non-claims growth by the bars at the bottom. The highest was in the Medicare Advantage and Medicaid market segments. Their report attributes the non-claims growth in these segments to a significant shift towards prospective payments and COVID-19 support programs. And then statewide hospital, outpatient, and retail pharmacy were the next highest categories after non-claims, while behavioral health continues to grow in all markets. Also notably, the cumulative growth in retail pharmacy and hospital outpatient drove costs in all markets from 2018 to 2022. And now I'd like to provide some highlights on the latest projections from CMS, National Health Expenditures for 2023 to 2032. This is a 9-year window that they're looking at. CMS issued this report earlier this month, and then based on an analysis we reviewed in Health Affairs, we note the following. Aggregate healthcare spending is projected to have grown 7.5% in 2023, which is up from 4.1% in 2022. This spending exceeded the gross domestic product growth of 6.1%. One of the factors that the authors attribute to this growth is the increase in the number of insured in the United States, which now stands at 93%. In addition, from 2023 to 2032, the average annual growth rate in aggregate national health expenditures is expected to average 5.6%, exceeding nominal GDP growth of 4.3%. So kind of looking to the future, that some of the factors they expect to drive spending is faster growth in healthcare prices relative to economy-wide price growth, aging of the population through 2029 when the last of the baby boomers enroll in Medicare, and increasing demand for healthcare relative to income growth. These factors all contribute to projected increases in the healthcare share of GDP reaching almost 20% at the end of the period, which is up from 17.3% in 2022. And then the next slide just shows just one more back. Shows some projections for per capita personal healthcare expenditures, ranging from 4.3 to 8.4% in that second row. And personal healthcare expenditures is the more relevant one in terms of just focusing on insured populations. And then CMS also projects per capita private health expenditures. That the ranges are also listed there, ranging between 4.8 and 8%, between 4 and 5.9 for Medicare, and then between 5.2 and 10.2% for Medicaid. The article includes several details, but just to include a few highlights. The analysts cite private health insurance growth in 2023 to 2025 as driven by faster growth in the use of goods and services, an increased enrollment due to enhanced subsidies in the individual market through 2025, as well as special enrollment periods for Medicaid disenrollments. Enrollment decreases after 2025 when the enhanced subsidies sunset, which is expected to lead to lower average per capita spending, and partially offset by continued growth in employer-sponsored coverage. And then for Medicare, the authors cite increasing growth is steadily increasing due to enrollment growth of roughly 2% per year. And then they also refer to provisions in the Inflation Reduction Act that impact spending and lower growth and capitation rates to Medicare Advantage. And then overall, as time passes, the associated spending and enrollment effects of the public health emergency and its provisions will diminish, resulting in spending and enrollment patterns that reflect longer-term trends that we've seen in the past. And then shifting gears to my last update, which is related to the advisory committee. So I'd like to remind the board and the public that OCA is still accepting submissions of interest to fill a vacancy in the advisory committee in the hospital bucket for a perspective that is the rural hospital perspective. We're still accepting submissions until June 30th, and our submission form is on our website. And then lastly, just to remind the public and the board, is our slide formatting key. Yellow refers to decision making authority for OCA, while green refers to decision making authority for the board. And I'll now turn it back over to the chair to facilitate any questions or discussion.
Sure. Terrific. Thank you, both Elizabeth, for the updates and the terrific staff augmentations to the team, and Vishal, of course, for covering a lot of ground on what's happened in other states, what CMS and our federal partners are telling us, and then, of course, what is to come in our agendas. And want to now turn it to board members to see if there are any questions, comments about what either Elizabeth or Vishal shared with us, and then we'll go to public comment as well.
Hey, Mark, this is Sandra. I have a couple of questions. Thank you, Vishal, for a great presentation. I'm curious, for the work plan related to behavioral health and behavioral health spend, are you going to have a special work group for that? Are you going to try to do that strictly through the advisory group? Could you elaborate a little bit on that?
Sure. So we'll be using the same investment and payment work group that we launched in June 2023, and we are turning to focus on behavioral health this next month in July. We are expanding our work group membership and inviting more specific behavioral health experts and folks that work in behavioral health or behavioral health providers to join the work group to expand our membership.
Vishal, just one question from me, or a comment. I found the reports from Oregon really interesting, and I really look forward to having our own versions of those. The administrative cost and profit line, it was so striking how different it was from the actual spending on care. When I first saw that, I assumed that that had to do with the depressed utilization during COVID and increased overhead. But then the following slide that you presented showed it's very intensively concentrated in Medicare Advantage and to a lesser extent Medicaid. And I'm just wondering if you have any analysis why it is in those specific categories and why commercial didn't show the same difference. It wasn't obvious from the reports.
Sure. So if we could go back to that slide. Just to clarify, the growth that I cited for Medicare and Medicaid, that was for the non-claims. One more, yeah. So the bars at the bottom, the statewide 20.9, 3.1, 84.2, 9.4, that's the non-claims growth, which is kind of any non-claims payment outside of fee-for-service. But the admin costs and profits is measured outside of healthcare spending, and that was in the previous slide, the 8% growth. Some of it has to do with some of the pandemic era Medicaid policies, which were paused, and then resulting in greater enrollment of populations during the public health emergency. And then it's an 8% number. In terms of dollar amounts, it's a much smaller component of healthcare spending. It's just that when there's a change, the 8% looks a lot bigger as a percentage. So that when they kind of isolate that and focus on the medical expense, that's when they stack that up against the target value.
Thank you.
Richard?
Thank you, Vishal and Elizabeth. One question, Vishal, you showed a slide that 125 registrations in the CMIR system and 3 applications. Can you say something about the other 122? Sort of what is a registration and what's going on there?
So I'll have our Assistant Deputy Director, Sheila, if you want to speak to that.
Good morning. Can you hear me okay? Yes. All right. So we have an electronic filing portal, and it's called Themis. And so people register. That's the registrations. And that's how they would submit their notice of a transaction. So once we had that up and running, which was of January 1st, we know that people are exploring it, and we've encouraged people to explore it. So you can go in with your email address, register, go through all the screens so you can preview what you do have to answer and how you submit. Nothing is submitted until you reach the final page and hit the submit button. So there are many healthcare entities, law firms, associations exploring the system. But to explore the system, you have to register with an email address. So that explains the other 122 registrations that have not submitted an actual notice.
Sandra, you did the expedited review, I think, for LabCorp because they were in bankruptcy. Is the thinking that entities that are in bankruptcy will always get an expedited review, or how'd you think about that issue?
Yeah, Invitae was the party in the transaction that had filed for bankruptcy, and there's our regulations allow for a request. And depending on the information they submit, OCA would make the ultimate decision on whether they grant it.
So that's not precedent setting.
No, it's not automatic, and there is a process they would need to follow.
And I would add, oh, go ahead. I would add for that, they had already filed Chapter 11 bankruptcy, and the bankruptcy court had already approved the sale. It was a very large sale, 239 million approximately. So they had to go through the federal Hart-Scott-Rodino filing. So they were coming to us with notice, having made it through all these steps. And so if they had not sold, they would be forced into liquidation, Chapter 7. So we considered all of those things when we evaluated the expedite.
David?
Thank you. Really a pretty minor question going to slide 13. But given the impact of enrollment trends and population growth that are affecting Medicare and Medicaid per capita growth, I was actually wondering, is this really per capita, i.e. where the denominator is the entire population, or is it per recipient in the programs?
It's for enrollee, enrollees of the program.
Okay, thank you.
Mark, I don't think there's more questions
Okay.
from board members that are in the room.
Okay, great. Just one comment from me. As we look at the behavioral health work group, which is exciting, I know that staff know the concern many board members have shared about focusing on behavioral health as part of this, connecting with DMHC and some of our other sibling departments to HCI, I think is going to be helpful in this space as they're looking at their own exploration of how cost trends and rates get built around behavioral health. So I'm sure that's part of the plan, but want to make sure as we sort of build that whole approach that that's included in what we do, because so much good work, not just at HCI and OCA in this space, but in some other parts of our government team. Okay, with that, should we move to public comment on these updates?
Great. We'll now recognize members of the public for comment on this agenda item. Please reserve comments on other items for the general public comment period. To ensure equitable access to verbal public comment, we will alternate between members of the public present in this room and those attending virtually. Those in this room may line up at the podium. Those attending virtually should click the raise hand button. Those dialing in can press *5 to raise your hand. It will track the order in which the hands were raised. Please keep your comments to 2 minutes or less so we can hear from as many members of the public as possible. And please note that while the Healthcare Affordability Board is committed to communication and transparency, board members and staff will not be responding to public comment. Additionally, the board may not discuss or act on any matter raised during the public comment period that is not included on the meeting agenda, except to place the matter on a future meeting agenda. I'll start with the individual at the podium.
Beth Capel for Health Access California. Thank you for the update, and we look forward to the discussion on behavioral health in the work group. It's a very important area that needs considerable development. Yesterday, the LA County Board of Supervisors adopted an action to eliminate almost $500 million in hospital debt by buying it all down. It sounds like a lot of money, but the estimate from the LA County Department of Public Health is that LA County residents have almost $3 billion in medical debt. There are several pieces of legislation pending that are related to medical debt that we hope make it through the legislative process and to the governor's desk, one including the Hospital Fair Pricing Act that HCI administers, another aimed at medical debt more generally. We were thus disappointed when we looked at the work plan not to see a discussion of measures of consumer affordability as part of the work plan, or a discussion of how OCA would work with DMHC and the Department of Insurance on rate review to pay off the important work that you're doing with respect to the cost target and the other benefits. So we hope that as we look ahead to future meeting topics, we will see more discussion of this, or perhaps it's just buried in an item that's not obvious to us. Thank you.
Thank you. Looking virtually, seeing no hands raised. Back to the room, seeing no one at the podium. That concludes public comment on this item.
Terrific, thank you. Okay, let's move on to our consent items and approval of our minutes. Vishal, turn it to you before we go to a vote.
Sure. We just have the May meeting minutes. They've been distributed and include any public comments that we've received since the meeting.
I will
Okay.
move approval.
Great.
Second.
So,
Great.
terrific.
Got a
Are there
motion.
any questions or edits by board members? Okay.
Doesn't look like
Seeing,
it, Mark.
okay, hearing none. Before we vote, let's see if there's any public comment.
Please step to the podium to make public comment on this item. If you're virtual, please raise your hand. Seeing no hands raised virtually and no one at the podium, that concludes public comment.
Terrific. Could we go for our vote, please?
Secretary Dr. Mark Galley,
Aye.
Dr. David Carlisle,
Aye.
Dr. Sandra Hernandez,
Aye.
Richard Kroenig,
Aye.
Ian Lewis,
Aye.
Elizabeth Mitchell, Dr. Richard Pan. We have 5 ayes, 2 absent.
All right, carries. So now we move into sort of the action part of our agenda and turn it to Margaretta to walk us through the updates. We, of course, spent quite a bit of time on this in our last meeting, and the objective of today is to hear where the staff took some of our questions, concerns, and updates, and then ultimately see if we're prepared to vote to adopt the model standards and goals. So with that, I'll turn it to you, Margaretta.
Thank you. Good morning, members of the board. So as noted, during this portion of the meeting, we'll continue our discussion on alternative payment model standards and adoption goals and review the feedback you all provided in May and the revisions we've made based on that feedback. And wanted to note that joining me today is Mary Jo Condon from Friedman Healthcare, who can help answer questions from the board. So just a few quick kind of reminders and process notes. So we have been meeting with the investment and payment work group monthly for the past year to support our development of the alternative payment model work, our primary care work, and then also now turning to behavioral health. So work group members have provided input as we developed and iterated on the proposals for the APM standards and goals over about 10 months and considered a variety of perspectives and in some cases collaborated across the group to develop alternative proposals. And this slide aims to attempt to summarize the extensive feedback from stakeholders on the APM recommendations and essentially under each month summarize the feedback we received from the work group, the advisory committee, the board, and the public comment process. And at each step, OCA continued to refine its recommendations to reflect the feedback. So for example, in February, we shared a draft of the APM standards and adoption goals to the board and received your feedback, and then went back to the work group and discussed this feedback, and then in May presented revised standards and goals that included your feedback, public comment feedback, and additional input from the advisory committee and the work group. So just as a high level for today's agenda for this item, we'll review the revisions to the APM standards and implementation guidance based on your feedback in May, and then I'll also present present more details on our data collection process for APMs and the types of questions it will answer based on some of your questions in May. And then we'll discuss again the APM adoption goals for the board to consider. So just as a reminder, as we always do, these are OCA's statutory requirements for alternative payment models, which include adopting contracting standards for healthcare entities and establishing statewide goals for alternative payment model adoption. So we'll start with the revisions to the alternative payment model standards and implementation guidance. So this slide aims to summarize the feedback that we heard from the board in May on the APM standards and implementation guidance. So I'll provide an overview of these 5 themes that we heard, and then provide an update on the changes we made or where we think we've addressed this feedback. The full set of standards and implementation guidance can be found both in the appendix of the board slides and in the memo shared with the board materials. And we also have handouts for you all of the memo and then a red line version of the alternative payment model standards and implementation guidance. So the first theme that we heard was requesting that payers design APMs to serve consumers with high clinical needs who may benefit most from comprehensive coordinated care. And in response, we've added implementation guidance 2.5, which reads, design innovative APMs to address the needs of all consumers, particularly those with the highest healthcare costs and most to gain from comprehensive coordinated delivery. Also wanted to note that OCA will collect clinical risk score data for members in APMs and those not in APMs to monitor the average risk score of participating members compared to non-participating members. We also heard a request for a stronger focus on continuity of care in a variety of ways. So we've revised implementation guidance 3.4 to emphasize the importance of continuous relationships between consumers and primary care teams. And note that existing guidance 3.1 also emphasizes providing sufficient primary care payment to support advanced primary care attributes like continuity of care. And then the board also noted the importance of prospective attribution in PPO plans. So we've revised implementation guidance 1.3 to be more directive there and more specific about using prospective attribution methodologies. And then we also heard the board wanted to ensure support for small practices implementing alternative payment models. So standard 5 is really focused on support for APM implementation for small independent practices and historically under-resourced providers. And this support includes upfront financial support, timely incentive payments, and a stepwise approach to assuming financial risk. And then also standard 10 emphasizes making technical assistance available to new entrants and other providers to support their success under alternative payment models. And then we also heard, heard from the board the emphasis on and the importance on aligning measures with those used by the sibling departments across the state. So we've updated implementation guidance to call for including, when appropriate, the 5 quality measures that are most aligned across the state departments. So we had broadly emphasized alignment across state departments previously, and so we've emphasized these 5 aligned measures in the update. So just as a recap, just wanted to share here on the slides, we have the standards 1 through 5. And again, these are detailed in your handouts and in the appendix, and standards 6 through 10. So now we'll turn to our discussion on alternative payment model data collection and goals. So we heard from the board interest in really understanding how effectively the data we are collecting will assess the impact of increased APM adoption on healthcare spending and outcomes. So our current proposed data collection aims to monitor several of these priorities identified by the board, and we'll walk through these in the next few slides. And then we also heard some inquiries whether OCA would track the uptake of direct contracting between employers and providers, and wanted to note that we will only collect data from health plans and third-party administrators, and we don't have plans to require employers to submit data on direct contracting with providers. So to address these 5 themes here, we'll walk through in more detail our data collection approach. So this table reviews the data elements OCA plans to collect and compares them with those collected in other states. We will collect information from payers regarding the penetration of APMs in terms of providers, members, and contract dollars. Payers will also submit their total non-claim spending, allowing OCA to calculate how much of the healthcare dollar is moving away from fee-for-service. Additionally, as I noted earlier, we'll collect average risk score of members participating in an APM and those who are not to analyze the relative health status of these populations. And next, I just wanted to walk through in more detail our data collection framework. So this slide shows the expanded non-claims payments framework categories. And as a quick refresher, OCA developed the expanded non-claims payments framework in collaboration with Friedman Healthcare and our team members at HBD. So HCI will be using this framework to both support non-claims data collection for OCA and the Healthcare Payments Database data program. So it crosswalks the HCP land framework. So the HCP land framework with more detailed categories, allowing OCA to track APM adoption by the HCP land categories and organize non-claims data into more detailed granular categories and subcategories. So these next slides show the categories and subcategories of non-claims payments that we'll be collecting through the expanded framework. So for example, under category 1, we have a variety of population health and practice infrastructure payments that crosswalk to HCP land category 2A. And again, here are the expanded framework categories 4, 5, and 6. And as you'll note here, we include a variety of different types of capitation and full risk payments that crosswalk to various categories 4 in the HCP land framework. So this next slide shows an illustration of the data that will be collected using the expanded framework categories. Sorry, I didn't realize this was. Thank you. Okay, so this illustration shows that the data that will be collected using the expanded framework subcategories and categories. So using the gold columns in this graphic, we see that the submitted data will allow us to show, to know the level of adoption of various payment arrangements such as capitation or shared savings, which the alternative payment model adoption goals are based on. Other categories such as practice transformation and performance payments are important for providers entering alternative payment models, but will not count towards our proposed goals. We'll also be able to know the number and % of members in each type of arrangement, the total spending of those members, and the amount paid via claims versus non-claims. And the data will also tell us differences in total spending by different types of arrangements. So the board's feedback suggested an interest in understanding the nature and adoption of different payment arrangements in California. So some states such as Colorado and Maryland collect qualitative APM data, and we think that the expanded framework will provide much of this information without requiring additional qualitative submissions from payers. And this slide outlines some of the types of information we'll gather through the expanded framework, including whether payments are prospective or retrospective or population-based, and whether the arrangement involves providers assuming upside or downside risk. And this next slide looks at some questions that we can answer using the expanded framework's detailed categories. So we'll be equipped to answer questions such as, we will be able to assess whether APMs are effectively engaging patients with higher healthcare needs. We'll be able to analyze the relationship between APM adoption and total healthcare spending. And we'll be able to examine the increase in non-claim spending as a percentage of total spending and identify which payment arrangements are gaining traction. So we think using the expanded framework, we will be able to answer many of the data questions the board considered at the last month's meeting with these more detailed categories, while also still being able to crosswalk to the national HCP land categories. So now I'll turn to the board's feedback on the APM goals. So here, some members expressed interest in accelerating the timeline to achieve the goals. Alternatively, many stakeholders have emphasized that changing contracts and adjusting care delivery for successful APM implementation requires a phased approach over time. And the recommended strategy, as we previously reviewed, involves incremental goals to foster immediate progress, maintain accountability, and ultimately achieve ambitious but long-term goals. So the board proposed aligning the commercial PPO and Medi-Cal goals to reach 75% of membership in APMs by 2034. And we wanted to kind of emphasize the difference we see in that most Medi-Cal products are managed care plans, which typically have prospective attribution methods, facilitating an easier transition to advanced APMs, whereas current PPO attribution methods typically result in a lower percent of members attributed to APMs. And then we appreciate the board's feedback and support for the 75% Medi-Cal goal and want to acknowledge the significant impact that this could have on advancing statewide APM adoption. Before we review the recommended goals again, this slide outlines some of the key decisions OCA made with feedback from the work group, along with the rationale for each decision. So for example, we recommend measuring progress towards the APM adoption goal based on percent of members to encourage a focus on population health. Recommend requiring APMs include a link to quality to ensure that affordability does not compromise quality. And then linking goals to the national HCP land framework to facilitate comparisons while leveraging our expanded framework to provide more detailed insights into the purpose of payments. So again, here are the goals that we presented and reviewed in May, and we're not proposing any revisions to the APM goals today, and we want to emphasize that these goals represent compromise reached in the work group over 10 months of deliberation, were developed in collaboration with our state sibling departments, Cover California, DHCS, and CalPERS, and reflect commercial PPO contracting cycles, and then also allow time to engage members and strengthen provider readiness to participate in alternative payment models. So I will stop here and just, do you want me to go through the rest of this or pause here? Okay, I'll stop here for discussion and turn it back to the chair.
Great. Thank you, Margareta. It worked better, Sandra, since I can't see everybody so easily. Maybe you could facilitate the conversation with our fellow board members.
Sure, Mark, happy to do that. David?
I was going to ask a question about Medi-Cal and FQHCs, but I think, Margareta, you answered it by saying they're already fairly far down the APM road already. But I was going to ask if the smaller FQHCs are actually kind of considered smaller medical groups also in terms of implementation.
Yes, generally I think we would consider small FQHCs, small practices, in terms of the support that we're looking for, small practices in terms of APM implementation.
And the current status quo from DHCS is probably that many of these organizations are already well down the road toward APM implementation.
I think there's a lot of work in progress at DHCS on implementing an FQHC alternative payment model, but you know that most of the Medi-Cal managed care plans are HMO models and therefore do at least have that piece of being capitation based, but would still be looking for a link to quality and for them to pay their downstream providers under alternative payment models.
Great.
So those are the transitions we think will happen in Medi-Cal, or we hope.
Thank you.
Can I just add to that? I mean, Margaretta's right, David. One of the first things I started working on with DHCS and our FQHC partners was just proposing an alternative payment model and methodology to the prospective payment system that the FQHCs live under as part of our federal sort of scheme, not dissimilar to how other FQHCs around the nation work. And it's a pretty complicated arrangement to move to the APMs. And we are just starting. One of the biggest hurdles, to be candid, was just the quality and precision of the data that we were using to build the APMs and track payments afterwards. So we do have sort of actively recruitment of FQHCs into this APM demonstration. It won't be statewide, but a number of clinics and clinic systems in the FQHC systems are electing to join that. So we have that, if you will, switch transition happening sort of as we speak. And then Margaretta's point is really accurate in Medicaid. So much of what the state does to pay for Medicaid goes to the plans, which is all per member per month capitation with quality, equity, and other reporting increasing since the 2024 model contract has spread. However, the level of work to look at what the plans pay their providers and those downstream delegated entities is, I think, where a lot of the work can occur to understand what sort of value and other APM attributes are happening in those contracts. So I think a lot of exciting work on the Medicaid side in this space.
Hey, Mark, if I could just follow up on that. So you think the uptake of FQHCs in the APM sort of pilot is starting to take off? What's your sense of the
Yeah,
obstacles there?
I think there are some clinic systems that are moving forward. I think many are hoping to see how this data, sort of just the cleanliness of the data, what data we're using. There's been just a lot of conversation on this piece. So some are moving forward, but I think others are certainly going to wait and see how that plays out. And that's why I think it's going to be I'm going to say my view, slower transition than I certainly had hoped or wanted, but certainly it's starting to move. And like many big things, moving away from the prospective payment system that has been in place for so long is a heroic move for some of those clinics. And we're sort of taking it small steps at this moment for sure.
Great, thank you. Richard?
Thank you, Margaret, for really very rich presentation and the work stream over the last many months. One comment, not so much about FQHCs, but about the small practice language, and I think the language is consistent with this, but we should be careful about encouraging small practices to take risk, and the language is consistent with that, but also kind of suggests that we want to be pushing these practices towards taking risk, and that seems like not a good idea to me in general. A question about the clinical risk adjustment language. Would each payer be implementing its own risk adjustment system, and will we have any information about what they're doing? And I guess related, this is a question probably more for Elizabeth, or is whether the HPD could implement a more consistent risk adjustment system, and will the HPD have information on whether a person is in an APM or not? So there are two questions there. I don't know which order you want to go on.
Yeah, at least from some of the initial conversations I've had, I don't believe an HPD will be able to tell if somebody's in an APM. We will know a lot about non-claims payments, and then the APM data collection is a bit separate because there's a definition that the non-claims payment has to have a link to quality. So it is a separate submission. And then as your other question was about risk adjustment?
Yeah, I mean, I would just follow up and say I do think, to the extent that the HPD data collection can be modified in the future to have information on whether someone's in an APM or not, we'll have a much better idea, much better possibility of really understanding what, if anything, APMs are doing for cost and quality. I think that the information that we're getting directly from the payers is going to be, my suspicion is kind of limited in being able to answer the questions that Margarita had on one of the earlier slides.
Yeah, that's something we could take back. I think the common data layout, that's kind of the industry standard, doesn't include that right now. So we'll have to kind of ask kind of why that is. But Mary Jo, do you have any insight?
Sure. So that's right, Vishal. The common data layout that is the industry standard and that the expanded framework was actually sort of inserted into does not say this individual is in an APM per se. However, the HPD will be collecting data on non-claims payments, as Vishal said, and it will be doing so using the expanded framework. And so while we wouldn't know, for example, that an individual is in an alternative payment model, we would know whether or not a portion of their care is being paid for outside of the fee-for-service system through a non-claims payment. And the sort of the circles of the Venn diagram there have quite a bit of overlap, right? And so theoretically, the HPD could identify the portion of total spending paid through non-claims for those individuals.
That would be helpful. And to the first question then, I mean, we're asking for clinical risk scores. Are we asking payers to tell us how they made them up or what they did to estimate them? Or?
Yeah, well, the proposal is that we would ask them to calculate the risk score for members in an APM, but by those categories for the expanded, I'll just use HCP land because it's a little more succinct. So categories 1 through 4 on that continuum. We'll know kind of what members are in pure fee-for-service versus the more advanced model and the risk score associated with it, not at an individual member level, but aggregated for all the members that fall into each of those categories. So we'll be able to tell kind of what members are being put into at least the relative risk score of what types of members are in APMs.
But again, my question was that there are many different ways to calculate risk scores. Will we know what each payer has done to calculate the risk
it would be each payer's respective methodology for clinical risk adjustment, and we would ask for a description of that.
And then just back to the earlier conversation, in order for a payer to do that, the payer must have information about which member is in category 1, 2, 3, or 4.
Yeah.
Whether that information could come to the HPD, it seems like it would be very helpful if that information were to come to the HPD. And I realize it's not part of the standard common data layout, but here we are changing things.
And Vishal, I think that we can follow up with you, but I think through the expanded framework and the mapping back to the HCP land categories, I think there's some opportunity there.
And Rick, we do hear the points, and actually HCI has a representative that serves on the NATO board, the NATO board that is developing is continually iterating the common data layouts. Certainly hear your point that it's not stuck in time, and so it's feedback that we'll take back to the HBD team.
Thank you. And then my last question, if I could, how much, Margaret, how much specificity or definition will there be of various terms? I mean, link to quality. How much is that in the discretion of the payer to decide whether a contract has a link to quality, and how much of it is knowable by anybody reading the contract? And if 5 people read the contract, they would all come with the same answer of whether there's a link to quality in the contract.
So we have defined those terms. I believe they should be in your appendix, but we do define in terms of a link to quality. That means that, and Mary Jo, please correct me if I'm wrong, that the payer, when they pay their provider, that their payment is at risk for quality, whether up or down, or an incentive or a bonus payment, that there is some kind of payment that is at risk for or tied to quality performance. And then also additionally for shared savings and shared risk, we have defined minimum thresholds of shared savings and shared risk in terms of what counts as a shared savings payment, and we proposed those thresholds. So if something is under the threshold, then it would not count as a shared savings model, because we want to make sure that we are providing that the payers are providing true incentives in terms of shared savings and shared risk to providers. So all of those are, we have proposed definitions in kind of in relation to the expanded framework categories and subcategories in terms of how payers would categorize those when they submit their data. So, and then, yeah, Mary Jo, anything else to add?
No, I think that's a great description.
Yeah, thank you. And I guess similarly, just the last question, I'm looking at slide 62. Is the definition of professional capitation, primary care capitation, behavioral health capitation? I mean, I think I know what those things are, but again, I can imagine different payers might interpret them somewhat differently, or shared savings and recoupments compared to performance payments.
Mm-hmm.
How much
Yes.
specificity are we providing?
So yeah, we are providing definitions of all of those categories and subcategories in the expanded framework, and those will be included in our updates to the data submission guide and the regulations that we come back to this fall. And we've released those proposed definitions over the last few months, and 6 months plus, and have collected feedback on those definitions from our investment and payment work group.
And my apologies, I said that was the last question. One other, which is, will there be a publicly available data set with the results of all these, with this data?
Yes, we will publicly report APM adoption by payer.
If somebody wanted to know for Blue Shield Medicare business or Blue Shield commercial business, would they be able to will they have access to these data on how much of their payment is in different categories, and the data that's on slide 62 and some of the other data we've been discussing? Yeah, there is a right answer to that.
Yeah. That's the hope, that we would be able to have more granular reporting on payer performance, and it's aggregated. This is more aggregate data. It's not member level, so given having said that, we do need to go through a process to make sure it's valid and reliable, and before we put out a data set.
Thank you.
Okay. Ian?
Yeah, I think you've done a good job responding to our feedback. I remain skeptical that APM adoption just by itself is going to incentivize better care, as opposed and reduce duplicative care as opposed to motivate withholding of care. I think that skepticism is borne out given how widespread APMs already are in the state. You know, I've approached this subject kind of taking comfort in the fact that we're engaged in the or we will be engaged hopefully soon developing quality metrics. But I hear you on the clinical risk scoring, that we're going to have many different scoring methodologies, and it sounds to me like all we're going to have here is the numerical index associated with that score as opposed to the clinical groupings that underlie the score. And so I think my ask to you is, as we develop the quality metrics, can we attempt to develop a common risk grouping approach that allows us to drill down and see how is APM adoption actually playing out with regards to the services that are needed, the services that are withheld, and of course consumer affordability.
Just to make sure I'm understanding your question, is it about standardizing clinical risk, or are you asking something else?
Yeah, I think I would like to be able to compare not just within a payer over time, but payer to payer, how performance is, how services are being delivered across different diagnostic groupings or whatever the appropriate clinical risk methodology is.
Yeah, I think they would each still be using their own clinical risk adjustment, but with regard to that component, I don't think we could, while there's commonalities in risk adjustment methods, I don't think we could necessarily compare them. Yeah, Mary Jo.
That's right, Vishal. I wouldn't suggest comparing one payer's risk score using a different risk adjustment methodology or tool to another. I do think, though, for each payer, you'll be able to see sort of the relative risk score of individuals who are attributed to different types of alternative payment models. I think, though, to sort of more get at what I think is your point, which is that you really want to sort of better understand the care being delivered, the needs of patients who are receiving care, and sort of how that is changing over time along with cost. Is that sort of what you would ideally like to see?
I think
okay.
The nail on the head.
So, which we, well, probably would really, right? But what we found is that the types of data collection that OCA is doing is great to sort of show us where the breadcrumbs are, and then sort of, working with data sets like the HPD to sort of understanding what type of bread it is, right? And so, looking at the HPD as a potential future source of analyses and sort of thinking about what that data set will be able to tell us in the future, because that data set is going to have far more granular information than the data that OCA is collecting. And I think that's the power of these data sets really working together and the collaboration that you see across those agencies.
Ian, I thought, if I could just build on your question, I thought that you started with trying to understand what the quality measures were so that we were having more of an apples to apples comparison on what quality was. Is that?
I think that's right, and not just, I mean, outcomes certainly, but more granular quality measures and shedding light on different practice models and services being delivered. So I think if I understand that may not fit neatly within the APM approach that we're considering here, but I would like to really explore that question with regard to quality analysis.
So I think, like Mary Jo mentioned, there's a few ways we could approach that. One is through analysis in the HPD, and then also as OCA develops its quality and equity measure set for understanding the performance of healthcare entities, so payers, provider organizations, and hospitals. That is something we can dig into more.
Great, thank you. Anything else from you, David? So I just, go ahead, Richard.
It's just a broken record given the last conversation.
Please.
Well, I appreciate, Mary Jo, your observation that one might be able to use the APD to infer who's in an APM by looking at non-claims payment data. Given the likelihood that the non-claims payment data may take some while to mature, and who knows, I do think I'd re-emphasize the plea to collect data in the HPD about APM membership, who's in an APM and who's not. Or I think that the questions that Ian is raising, we're just not going to be able to get answers to.
We hear you.
So I'd maybe just add a couple of comments. First, really appreciate all the work that was done from the last meeting to this one, particularly on the standards, and put a fine point on this notion of the importance of continuity in primary care. And I'm wondering, in the standards, we talk about encouraging that continuity of relationship. Do you have thoughts about how that might manifest itself?
Sure. So I think, in general, we are looking, one, for payment to primary care providers, one, to increase, and then also to support that continuous relationship, and advanced primary care attributes like team-based care, emphasizing continuity of care, integrated behavioral health and primary care. So those are the types of attributes that we're looking to emphasize through primary care payment. And then also, want to emphasize that payers should encourage consumers, and potentially even, could follow the approach of Cover California and CalPERS to require members to, or not require, but to encourage and assign members a primary care provider, and encourage that relationship between a primary care provider and a consumer. So those are a few ways. And then there are other ways potentially we could try to look at primary care provider continuity, either in HPD or other ways.
Does the HPD have the ability to do that, to look at continuity or to be able to assess continuity, Major?
So I would speak more broadly about APCDs generally, because the HPD is sort of, getting up and running. But at maturity, APCDs are able to look at individuals who are attributed to a primary care provider using sort of your attribution rule of choice, and then look at how frequently those members were attributed to that primary care provider, or how frequently they saw that primary care provider, and how long that relationship has been going on. These analyses can be a little bit trickier sometimes than they sound, because, for example, let's say that, one time you go to your primary care provider and you see them at one location where they bill under one MPI, and then you go somewhere else, et cetera. But I think we can sort of get a rough estimate, especially when we look at billing by the organization, because really I think, what we're looking for is sort of an individual to have an attachment to a care team, not an individual to have an attachment to a specific provider.
Great, super helpful. And then I just wanted to comment as a process matter that I appreciated the advisory committee sort of moderating the enthusiasm of the board for the rate of these adoptions. The importance of having experts sitting at the advisory committee who are working in this space is, I think, valuable to the board's input, notwithstanding the fact that there's a sense of urgency around trying to get better value out of care. So I just wanted to acknowledge that process question. So Mark, I'll give it back to you now. I don't see anything else from the board.
Okay, thank you, Sandra, and fellow board members. With prior knowledge that both Richard Pan and Elizabeth Mitchell were not available for this meeting, I did one-on-one, still respecting our Bagley-Keene requirements, reach out to see if there was any feedback given the importance of this conversation to the future work. And I just wanted to take a minute and, if okay with the rest of the board, read some of the comments that I noted that both Richard and Elizabeth had. I'm going to start with Richard Pan, who said on the APM slides, section 2 on payment models, he said 2.2, we should consider rewarding, quote, improved health outcomes on top of the process measures listed. As it relates to section 3 on primary care 3.4, he says he doesn't think the main problem is consumers needing encouragement, especially for high need patients. Payers and plans need to incentivize and promote the continuity relationship with a primary care team. Uh, with and the relationship with that team expanding, including expanding provider networks so patients are less likely to be forced to change their primary care team. As it relates to 3.1, that it addresses primary care, or sorry, payments, but not provider networks or other structural factors that may disrupt continuity. Can we at least require data on patient and network continuity over several years? This probably relates a little bit to the conversation we had about what our HPD data will give us and how sort of longitudinal that might be. On section 3.5, he recommends that we substitute visits with services. He said many primary care services are not visit-based, although to get paid, some PCPs make delivering these services into visits, which occasionally burdens the patients. And then his final comment was on section 5. He said, quote, appeal to, end quote, is probably not the right words. Is it rather, quote, is fiscally feasible for, end quote, maybe more actionable. If we really want small independent practices to participate, then it needs to work so they aren't putting their personal livelihood at risk. I think that is a bit to the point that Rick made. And those were the comments from Dr. Pan. And then as I look to what Elizabeth Mitchell shared, she said she remains concerned that we will not actually improve accountability or enable care delivery change for the better. For better costs and or outcomes, and that she would not necessarily be supportive giving the changes to this. So these are not proxy votes. These are meant to be proxy comments, but given the importance of all of our voice in this conversation, I wanted to share those. On my regard or my behalf, I will just say that I appreciate the level of work that went into this. I very much, as we have on other important items to the board, appreciated both the team, Margareta Vishal, you and your team's real attention to our feedback between meetings, that you looked at it closely. I know that we had some other conversations about where we could go on this. And to Sandra's really important point, the pace at which we adopt these goals, I think is really important. That if it takes a little longer than some of us would have liked, but we get there, I think it's critical. And my only other comment is that I am excited to see how, through the evolution, not just of our own work, but that of the HPD and our ability to track this data over time, possibly connecting it to whether APMs are at play in some of that data, this continuity piece reflective potentially in that data as well. And then to Ian's really important point, how can we connect it to those quality measures that matter the most? I look forward to today's discussion and vote to just be the beginning of making sure that as we adopt and expect APMs a little bit more broadly in California, that they're actually driving towards some of the outcomes that I think we most deeply care about, including affordability, but quality and equity as well. So with that, I think we can move to our public comment. Well, actually, we want to put up, let me turn it back. Before we do that, we go back to Margaretta to actually put up the goals.
Thank you for all of that. And just to note, we've been taking notes, and if the board, we'll go through the action item, and if the board would like, we can make a couple of the edits that were recommended before we take the motion.
Yeah, let me suggest that the recommendation from, I think it was Senator Pan on 3.5 to describe those as primary care services versus visits is a really good suggestion, and I would encourage us to use that language. And then on this issue of small practices and the feasibility for those, I think if we could figure out wording there on number 5, that would also be helpful. Okay, back to you.
Okay.
Marguerite.
So, so here we propose kind of generally a draft motion for the board to vote on whether to approve the 10 APM standards for payer-provider contracting, and then asking the board to also vote on the APM adoption goals for % of members attributed to HCP land categories 3 and 4 by 2034. And so we'll go through those in more detail. So these are the first 5 standards, and we could come back to revise standard 5. And then again, these are standards 6 through 10. And then these are the proposed APM adoption goals with 2-year goals leading to the 2034 goal.
Okay, board members, anybody? Good?
So Jean-Paul, would if we were to just go to that slide and correct the appeal to read physically feasible, if that is the motion that the board would like to make?
Yeah, I'm happy to make that motion with those changes, Jean-Paul.
I will second it.
David?
Just a question.
Yeah.
I think there's also a suggestion to change visits to services.
Yes, we're going to do that. We're going to make that change too.
Yes, we can make that change as well. So, and here the motion is framed as the board adopting these 10 high-level standards, and then we will revise the additional language underneath.
Okay, if there's any other comments or questions from the board, if not, we should go to public comment on this.
We will now recognize members of the public for comment on this agenda item. Please step to the podium if you're in the room. If you're online, please raise your hand. If you're dialing in, please press *5. Please keep your comments to 2 minutes or less so that we can hear from as many members as possible. To the podium, go ahead.
Beth Capel on behalf of Health Access California. First, we'd like to start by commending to the board and staff a model that Covered California uses of being a learning organization, which means that you learn over time. I think it's particularly apt for this because we all share the goal that we'll have alternative payment models that, as Dr. Galley just said, lower costs and improve quality and improve equity. And it is not clear to me that what is being proposed is sufficient to accomplish that. I think the board discussion last month and this month has been very good in that area. We would also note that with respect to risk adjustment, there is already standardized risk adjustment in the individual and small group market. So we have a model that makes that work and that we know can work. With respect to small practices and taking risk, I would simply remind the board that California law requires that a practice that takes a certain amount of risk is required to become a risk-bearing organization, and that those laws are there for a very good reason. Some of us remember the mid-90s when physician groups were going bankrupt left and right and don't want to ever go back there again. Thank you.
Thank you. Looking virtually, Anna, we see your hand raised. Go ahead. Anna, you're unmuted on our end. You might need to unmute on your end. We'll go ahead and switch back to the individual at the podium if you'd like to step up, and while we get Anna figured out.
Amy Blumberg with the California Medical Association. We would also like to echo the concerns raised by Board Member Cronick and Dr. Pan concerning standard number 5 and concerns about risk related to small practices that they would be taking on with the APM adoption. Just as a reminder, during the work group meetings, there was conversation about this, and smaller practices, it was said that smaller practices would not be expected to take on risk. We think it's important that OCA stick with this commitment, and we appreciate the revised standard and the continued work on this.
Thank you. Looking back virtually, Anna, you had your hand raised. Would you like to make a comment?
Yes, please. Can you hear me now?
We can. Thank you.
Excellent. My name is Anna Malinell, the Movement to End Privatization of Medicare. I appreciate the opportunity to speak. As we know, value-based payment models, which are the alternative payment models, were jump-started by the Affordable Care Act as ACOs and the Center for Medicare and Medicaid Innovation models. They've been around for about 14 years, and so far there has been no evidence that they have saved Medicare any money, and in fact they have cost Medicare money. In fact, the CBO report from September of 2023 published that instead of saving Medicare the $80 billion over 2 decades that they were expected to save, CMMI spent $5.4 billion more than it saved in its first decade, and it is projected to continue losing money into its second decade using these value-based payment models. So further, there is scant evidence that value-based care improves quality and significant evidence that they worsen healthcare equities. So I understand that you cannot answer my questions, but I think that if we're going to be promoting alternative payment models that have been shown to increase costs and to worsen quality, do you have any evidence that APMs lower costs without harming care, or that APMs improve equity? Thank you.
Thank you. Looking back virtually to the individual at the podium.
Excuse me. Hi, Marissa Montano with the California Academy of Family Physicians. On behalf of our over 10,000 family physicians and residents, we thank OCA staff and members of the board for your commitment to prioritizing primary care, and are supportive of the adoption goals and the refinements made, especially around the continuous care relationships with primary care providers, and also appreciate the emphasis and sentiment on measuring that continuous relationship between physicians and patients. Appreciate the opportunity to engage on these issues. Thank you.
Thank you. Looking back virtually, seeing no hands raised, noting for the record we have about 104 virtual attendees. Looking to the room, seeing no one at the podium. That concludes comment on this item.
Mark, there's a motion on the floor with a second. Do you have anything else you'd like to add before we take a vote?
I just want to make sure the changes, I'm looking at this slide, what we changed on 5, is the other change been made?
The other change is on 3.5, I believe.
Yeah, so Mark, the board is voting on 3, and then the staff will change. You're
it.
voting
Okay.
on sort of the bolded part, and then
Right.
the other part is we will change visits to services.
Great. Okay. No, no other comments, so let's go ahead and take our vote.
Secretary Dr. Mark Galley,
Aye.
Dr. David Carlisle,
Aye.
Dr. Sandra Hernandez,
Aye.
Richard Kroenig,
Aye.
Ian Lewis,
Aye.
Elizabeth Mitchell, Dr. Richard Pan. 5 ayes, 2 absent.
All right. Congratulations. That's another big decision for this body, and appreciate again the staff and the team for getting us here. Elizabeth, Sandra, what do you want to do? We were
Yeah, Mark,
potentially.
we were just talking about that. We're going to go to informational items, but a number of our guests we are still waiting for. And so I think the suggestion here is that we break early for lunch and come back at 12:30? 12:10. Okay, so that works for you, Elizabeth, board members? 12:15, okay. We're gonna break for lunch and resume at 12:15. Mark, I don't know if we'll have you then, will we? And if not,
You will not. Yeah, I will
Okay.
not. Just thanks again, Sandra, for carrying the meeting forward, and I hope everyone has a good lunch, and I look forward to seeing everyone in August in Monterey.
Thank you for joining us, Mark. Bye.
Okay, bye.
So welcome back, members of the public and board. We're going to move on with our agenda. So I think we need to do roll call, yes? Yes. Please.
Yes, good afternoon. Secretary Dr. Mark Galley, Dr. David Carlisle,
Present.
Dr. Sandra Hernandez,
Here.
Richard Kroenig,
Here.
Ian Lewis,
Present.
Elizabeth Mitchell, Dr. Richard Pan, Don Molds. 4 present, 4 absent.
Okay. With that, I will, who's going to introduce Peter? I know him, but okay, Margareta, please.
Yes, good afternoon, members of the board. So before I introduce Blue Shield to present their cost reducing strategy, I just wanted to provide a quick reminder of our cost reducing strategy project. And the goal of this project is to highlight examples of successful cost reducing strategies that also maintain or improve quality. And we at OCA are working with health plans and hospitals and physician organizations to highlight examples of strategies that have demonstrated results in their organizations. And wanted to note that OCA has not independently verified information about the strategies or the results provided by healthcare entities, and we're not endorsing any strategies. We have identified these as helpful examples of cost-reducing strategies that can be a resource to others. And wanted to note that we are also seeking additional examples of cost-reducing strategies, and please contact OCA using our general email inbox if you would like to propose a cost-reducing strategy for consideration, and we'll follow up to learn more. So now I'd like to introduce Peter Long, a PhD, who's the Executive Vice President, Strategy and Health Solutions at Blue Shield of California, who will share examples of cost-reducing strategies at Blue Shield. So Peter, we'll turn it over to you and let us know when you'd like to advance the slides.
Perfect. Thanks, Margareta. Thank you all for the opportunity to speak with you today. So as you can see, it's a great honor to be here among folks who I've known for many, many years. So great to share some of the work we've been doing at Blue Shield. And I think the frame for my remarks will be, we're trying to build an ecosystem. So we don't believe that there's a magic bullet of a single payment model or a single approach to do cost containment. The healthcare system is incredibly complex, both in the diversity of people who are in California, but also the healthcare system, the different types of payers, different lines of business. So what I'll speak a little bit about is our ecosystem approach with some very bold bets, and some of you read about those in the media. So incredibly taking on industries and taking on kind of cherished practices. A series of payment models, which I'd say is the undergirds of pay-for-value type models, which undergird so much of our work. And then the third part, I think, Margarita, to pick up on your point, an example, I'll just give you one example of taking something that's not necessarily designed only for cost savings, but actually to deliver value. So, right, making sure that we're not just doing cost savings or cost of healthcare approaches for the sake of cost of healthcare, but they actually have to be paying for things that our members want that actually improve their health, improve their access to care and quality. So next slide. I think many of you are familiar with Blue Shield. We have 7,500 employees across the state. We're in every region, every county in California. We have 4.8 million members and growing, which is, I think there's good news coming in terms of a couple of new contracts that'll push us over 5 million members. So we're a significant player in the marketplace. Our annual revenues are around 24 billion. And now for more than a decade, we have capped our operating income at 2%. And so the 2% was to say, how much operating income do we need as a nonprofit to maintain our risk-based capital, and then make investments so that we can continue to improve care and continue to make investments in, for our members on behalf of our network and on our infrastructure. So we have maintained the 2% pledge every year. If we get more than that, we give to our charitable foundation, which I had the privilege of running for 9 years, but then also we either give back to our members in a rebate or make a significant investment in something that's for the good of the state. So to build that's beyond benefiting Blue Shield members. So we deeply believe in the 2% pledge. We think it's incredibly helpful statement to our competitors, but also as we're having negotiations with providers and others, that Blue Shield has said, we will not earn more than this. Now let's talk about how do we deliver affordable health care to our members. So that's a little bit about it. We also just are a tax paying, so we are a nonprofit. We pay both state and federal taxes, fully taxed. But we are a mission. If you ask any of the 7,500 people at Blue Shield, why are you there? You will hear it is about the mission of providing health care that's worthy of our family and friends and sustainably affordable. So I would describe us as a highly mission-driven organization. Next slide. So this next slide should be familiar. I think it looks pretty much like other plans. So this would be do we cover the boxes of high quality care? That's what we're here to do, right? Creating enabling a personal high quality experience. We obviously want to take feedback from the market. Are we doing the right thing? So if we're doing the right thing, the market will tell us and we'll begin to grow. We are stewards of the resources, right? So none of the resources emanate with Blue Shield. They come from either the member or the government or an employer. So we need to be incredibly good financial stewards. The 2% pledge is one way, but that's probably the most visible. Strong emphasis on is the work meaningful for our employees? Because we believe if it's not meaningful for the 7,500 folks who work for Blue Shield, then it isn't going to be meaningful for the providers who we partner with, or it's not going to deliver on the needs of our members. And you've, I think, seen Blue Shield, whether it's on being an early supporter of cost containment in California and a stable supporter of we need to make healthcare more affordable, or data sharing and data exchange. Blue Shield is not afraid to take positions, public policy positions that are in the interest, we think, of delivering better healthcare for all Californians. And then our newest one is, and we're probably late to the game, and my goodness, healthcare is late to the game, is be more digital, simplified, and automated. So one of the ways I think to make healthcare more affordable is the right-hand one about digitization, simplification, automation of healthcare. And then clearly our values to be honest, human, and courageous. So let me just next talk about some of our big bets. I think you all probably last August read about our endeavor to take on the pharmaceutical industry and create our own pharmacy benefit administrator. So deal with the opaque world of pharmaceuticals and the inability to get a net price. Just like we get a net price for a hospital or a physician or for other parts of healthcare, it's very difficult to get a net price for drugs. And whether it's in the medical benefits or something that's administered inside that, or from a pharmacy. So we have taken it upon ourselves to create a huge endeavor that we've been at for the last 18 months. We'll be launching January 2025, a modular, transparent pharmacy benefit administrator. And that's the first step. What we really want to get to is net price transparency. And then ultimately we need to get to is a value-based model for pharmacy. That's ultimately where we have to go. That probably be blended with healthcare at the end of the day, with medical services. So we are on that journey. We've announced it to the world. We literally, and we have, I think it's a harsh metaphor, we have burned the boat. So there's no turning back from this. We will be administering this benefit going forward. We just announced actually today about a real-time digital health record. So combining all of the information we have. Hey, Don, how are you? Combining all the information we have about our members, whether they were on Blue Shield or not, their clinical data, their claims data, so that we have a picture so that each time we're kind of on the health journey with our members. And second is that they can control their journey. So if we give them access to all of their data that we have, they can decide how they're getting care. And as they move through the world, they'll have the ability to control their own health journey. And then we've announced last year a partnership with Oracle to, we call it Claims Reimagined, but it's really about taking the friction out of the healthcare. There is so much administrative complexity. So we're starting the endpoint, let me say, we're starting at the endpoint, which is we want to automate claims such that you could adjudicate them and settle them in less than 10 seconds. You can imagine we need to simplify our benefits. We need to simplify our contracts. We need to change literally the entire end-to-end process. We think that's a task worth undertaking, and we think that will be transformative. It's not a 6-month or a 1-year task, but we believe, like changing the pharmaceutical model, it is worth pursuing and something that we're willing to partner with a technology company to address. So that is those are examples of our long-term, we call them our bold bets of these are things that need fundamental transformation. The reality is we live in the marketplace today and we have to compete with other health plans today. So I'm going to switch and talk a little bit about some of our pay-for-value models, and then just an example of how we partner with a health technology company to give you a flavor of, while we are taking on these big, bold bets that we believe will be transformative, we also are doing the work today to make healthcare more affordable. Next slide. Actually, we can skip 2 and go to the next one after this. So now I'm going to switch gears and talk to you a little bit about our pay-for-value model. I think the first statement is the most important one. The fee-for-service system is broken. That is fundamentally, we cannot go forward with the fee-for-service and make healthcare affordable. That means, though, it has to be a value-based. It can't just be paying in a different, inefficient way. It actually has to be paying for services that produce outcomes and that are sustainable for providers, right? So it has to be a model that works, that is efficient, high-quality care, and paying for value, we believe, can produce some results. I have a few that I'll share with you, early results from some of our work. Just to put in perspective, we have 22 different currently value-based payment models. We think there'll be quite a few more than that when we're done. As you think about primary care, different flavors, I'll talk to you about a primary care based on readiness and system, what type of provider they are. We have to then think about system-based models, accountable care organizations. So for integrated systems, you think about specialty care. And the one where we, I think, have more work to do as an industry and we're thinking about is chronic care management, care pathways. So I would say to you, that is our work in progress. But the 4 others, I'll share a couple of examples of models where we are driving that work forward at scale. The goal of it is to achieve the quadruple aim. And then to promote health equity. So a recent addition to all of our models is to take into consideration, are they making care more equitable by race, ethnicity, language, sexual orientation, gender identity, or not? And so we are building in an equity component into our payment models from the beginning to ensure that by doing pay for value, you're not only working with a certain group of individuals and giving them a different level of care and creating unintended consequence. So that's the relationship. Our goal, just the headline is, our goal is to get to 100% value-based payments. We are for 2024 will be at 59%, so about 60% of our payments will be under a value-based construct. The other thing that's really important about Blue Shield is that we set ourselves, our definition is the federal definition. We've adopted the HCP LAN. So the federal definition of what is value-based care that the Center for Medicare and Medicaid Services have adopted. So we orient ourselves not by our own standards, but to the national map of, is this truly putting folks at risk, either upside and downside risk, and we're paying for quality. So the 59% is in category 3 or 4 by the national standards. So just again, we didn't just make the number up and say, hey, we're at 59%. It's actually part of a move to how do we compare it across the country. Next slide. So this, I mentioned to you, the 4 that are in play, the 4, and we think, I think, we'll skip to we, but primary care is the most important. That is the entryway, and we think primary care is different than the others. We think the others, you need a model. Primary care, every primary care doctor should be in, or primary care provider should have an option to them to deliver value-based care and to support their practice if they want to stay independent and practice in the way they want. So you'll see that we have multiple iterations. And then the third one, I think, is the most interesting for this group, and I think it is the one where we'll know we're successful. We've actually had quite a bit of success on our primary care model. I'll show some statistics on that. So for independent practices with Blue Shield members, we have a fee-for-service model with payments for quality bonuses for practices that have lower infrastructure. The third one truly will be the game changer. Can we get large systems to adopt a primary care and advanced primary care model and drive that work forward in a way that we know the payment goes all the way down to the provider? So it doesn't just stop at the system level or at the independent practice level, practice association. It goes down, and then we know that providers, because we know that that's what drives the behavior change in the practice. We are going live with that. It's going to be fun. It's going to be interesting. And that's kind of why you do this, as to how do you drive that work forward. The two in the middle on hospitals, I think, are pretty well established. The Accountable Care Organization, ours is more than a decade old. Our big improvement there was it was a primarily cost-driven model. So it produced, and there's health affairs articles and others to talk about trends for our Accountable Care Organization over multiple years, kind of a lower trend versus non-accountable care organization. What we've added are dramatically increased our quality payments and our member experience payments to make a more balanced, in that case, AAA model, rather than it was a cost-driven accountable care organization. So it's not successful unless we're also delivering value, high quality care, and a better member experience. We are using retrospective bundles. They're easy to administer. I think ultimately we want to get to prospective bundles. So retrospective means you look back and say, this was the episode of care, whether it was a knee surgery or hip or others. I mean, ultimately, we want to get to prospective. I think our philosophy is you need to build trust with the providers, and we all need to see the same data before you start into it. Let's start future looking. We're going to take the risk together and take the leap. So we're having very good success both on the reductions in cost on those models, and also participation rates have actually been, people are pretty excited because every one of our models actually has been co-designed with the medical society, because our thought is there's nothing that the health plan can put out there without the input of actual physicians, actual providers, and the support of the medical society. So we think that's been really important to build trust. A couple of models in oncology care. I think there's more work to be done there. That is a place where ultimately you'll see our work come together on prescription drugs and on oncology to take some of the margin out of the cost of the pharmacy and actually separate, this is what it costs for the drugs, the oncology drugs, and this is the administration. That's where we want to end. We're not there yet, but we're on a path. We think that will be delivering the highest value. And then I'd say our work in progress is this chronic care management. It's folks, I think it's been harder for us to, what's the full quantified? How do you manage chronic care? What's your time period? What's the outcome you're looking for? We're working on that. And we believe ultimately that is, we have to solve that. These other things are a great start, and they're more about managing cost and utilization. This is about managing care. And so we are actively testing models there, but I don't have that ready to show for you today. Next slide. All right, so this is the good news. This, I pointed out to you the 4 different versions. We believe this can cover every practice, or every primary care provider in California who's a member of Blue Shield. The results are we've got a 9% total cost of care savings year over year. So we used a difference in difference model. So we had a comparative group pre, a comparative group post, and then the intervention group pre and post. And so the difference in spending, total cost of care, was 9% less expensive if you participated in our hybrid model, the top for independent practices. So we think that's encouraging. The purpose of this one, though, was to drive greater access and better quality in primary care. For perspective, we're not at full scale yet. We have identified about 600 practices that have at least 100 Blue Shield members. So it's hard to do a per member per month capitated payment unless you have a big enough population. The variability is hard. So we set a threshold. You need to have 100 Blue Shield members in order to do it. And we've got just about half. So 600 eligible practices. We've got about 300 enrolled. We think this is, again, very, very successful. And it is roadmap that we're going to use to engage IPAs and say, what's your equivalent? This is what we want to do. And you'll see on the next slide, we've aligned all of our measures with Cover California, with CalPERS, and with Medi-Cal to ensure that we're paying for and incentivizing the exact same outcomes that were being expected for our major purchasers. Next slide. And so we've gotten good early results. These are a little more formative. These are internal early results on it is improving quality as well. It's not just enough to be lower total cost of care. And you can see these measures. I apologize if my boss were here, he would have a conniption for my acronyms. So, but I can go through that. They're the acronyms of for blood glucose, hypertension, or blood pressure. I'll get the list here of them. So they're the measures, though, of colorectal cancer screening, breast cancer screening, childhood immunizations, and weight. Exactly. Yes, you're familiar with those, Don. That's good. So these mimic. These are, again, same difference in difference improvements over year. So not massive, but we think we're directionally correct. And we think it's encouraging because this is not just our early adopters. When you're at 45% of eligible practices, you're actually getting folks like, oh, I'll try this or not. It's not the enthusiasts who are probably already doing a decent job. So we're encouraged of directionally cost savings in primary care and improved quality. And we think this is scalable. So our next big decision is, when do we say this is the way? When you do business with Blue Shield, this is the way you do business. We're very close. I don't want to make any announcements here today, but I think that is our next decision. We think directionally we have enough data that this is going in the right direction. And this is a precursor to advanced primary care, which we believe we're working on with PBGH and others, that you put this package together with an advanced primary care model and start to spread it across the state. Next slide, I'm going to do one more just different example here for you. So this is an example of we are flooded with innovation in this state and in the country. So this is an example, a reverse example. I'm switching gears a little bit. As I said, we're not short. I'm on the Peterson Health Transformation Initiative. We're not short on evidence-based solutions, MAVEN being one of them for maternity care. The big challenge for health plans is, how do you get utilization? How do you get engagement so that you actually are driving the outcomes that you're looking for at scale? We have so many programs and solutions that are offered, but they're not actually taken up, right? So they're proven to be effective when the population who actually uses them, but it's incredibly small uptake on this. So you all may be familiar, as I said, MAVEN is available to other plans. What I think is encouraging for us is our ability. We can go to the next slide. It has a number. You can see this, and I'm going to go through some of the examples. We've gotten great participation. I think the key is engaging the members to actually use the service. So with more than 3,000 participants, and that they're joining early. So 2/3 are joining in either the first or second trimester, so you're deriving the benefit of connecting folks with care, of the educational components of it. I'm staggered. I don't do 80 minutes on any platform. So I'm staggered by the results of 80 to 100 minutes on a platform with an incredibly high net promoter score, and people are actually using all the services. So what we think, if you think about our vision for the future, is a payment model that is rational and scalable and makes sense. Then you add on solutions like MAVEN to say, when you're on that care pathway, we're going to go with you. We're going to give you high value, high quality care. And we know that if you're in the MAVEN program, you're getting the services. These folks have been vetted, the providers. You don't have to think about utilization management, prior authorization, all of the things in a plan that are more traditional elements of how do you manage cost and manage care. This is actually a gliding pathway that there's a super high net promoter score, 75, so that our members are actually enjoying it. We know that they're getting the high quality care. So we believe that this is a precursor, and this is what we're modeling for when you think about chronic care management value-based models. And then, as I said, so it's bold moves where we think the industry is intractable. We're going to take it on. A platform of value-based payments across that are sustainable and scalable, and then anchoring in solutions that are engaging and actually providing value to a member. We believe that's the combination. That's kind of the modern health plan moving forward. And I'm happy to answer your questions.
Great. Thank you, Peter. I'll open it up to the board. Any questions, comments? Maybe I'll start, and then I'll go to you, David. You had on your slide, Peter, thank you for your presentation, for all the many ways that Shield is supported cost containment and quality in the state. So I think everybody would agree with that. One of your slides talked about behavioral health and scaling behavioral health. I'm curious you didn't comment on it. That's a challenge that I think everybody's aware of. Thoughts and progress that Shield has?
So we've done good design work on that. So we insourced Beacon from Beacon on Medi-Cal and Medicare. So where we are on the behavioral health is we have done the design of what the future state is, and where our initial investment is navigation, because we think most people get stuck at you can't actually get into the behavioral health system, and you're not sure when you're in, where do you, like what type of services you need and how that works. And then the second big investment, which we're incredibly excited, this is one where I think everyone should do it, hands down, is the collaborative care model. We've found for very little new investment, incredible uptake. I mean, just incredible uptake from primary care providers about wanting to integrate for the mild and moderate behavioral health conditions and integrate those into their practice. And we've got support from the group up in Washington State. So those are two areas. I would say we can only change part of the world at one time. And so next on our list, on the priority list, like in the on-deck circle, if you're a baseball fan, is the deep investment in behavioral health transformation. So we have our roadmap. We've made initial investments in navigation and in the collaborative care model. And so the next, though, is a full, of the scale you would think about with Pharmacy Reimagined, of the scale you'd think about with reimagining claims. That's our vision for it. I think you'll see it more in mid-25 to 2026.
Helpful, thanks. David?
Well, thank you, Peter. Great to see you again. Great presentation. And congratulations on all the exciting things going on at Blue Shield as well. I'm especially noting the 2% pledge. That's a great thing as well. Actually, Dr. Nat has actually hit the topic I was going to cover because I noticed the same thing on behavioral health.
Sure.
I wanted to ask you to elaborate more on primary care and what do you consider to be the primary care entry points? For example, we're discussing, say, OBGYN, and do you consider that part of your primary care environment?
We've not, we're using not OBGYN in our models because we have a separate model. So I guess gynecologists would be. I think our approach, though, is we have the model. We could adopt it and we could adapt it. And I think that's a good point to understand. And because there's so much unmet need and people are accessing the system in different ways, it's a good challenge for us to be as flexible as we can be and make sure the models work across. We've done it more for family practitioners, internists, pediatricians. So we've done family practice, DOs. But it's a good challenge. And one of the things that when your models meet the world, like virtual care and things like that, how do you make sure that your models are flexible enough that it actually is responsive to how people use the system today and who they're identifying as primary care? I think it's a good next step for us if we want to be at scale and be sustainable.
Rick, please.
Thank you, Peter. Always wonderful to hear about the work you're doing. Couple of questions. In the advanced primary care model or in the primary care work, is the investment in primary care increasing? Is your spend on primary care higher than it was? And if so, kind of what was it and how much has it changed?
Sure. We set the model to be actually an increased investment in primary care. So we literally set we started with the 2019, so pre-COVID amount, and the hybrid model and we literally went out and did the calculation in front of every group and said, you will get more money. So we said around 10% more, a 10% increase per practice. We wanted to make it not in the abstract level, but in your practice, for the same attributed patients would get 10% more by doing this model. So we're really clear because there's a long history of we're going to cut your payment and give you flexibility. There's a long history of that. We wanted this to be, we actually want you to be successful. And part of why the 9% is good for savings and total cost of care, it includes the additional investment in primary care. We need to do more. I think we see your target. And we think it's an impressive and great target for primary care spending. And we're prepared to meet both of the targets, will be the cost target and the primary care spending. I think we're on a ramp, though, like most health plans to get there.
To talk about primary care benchmarks.
Yes.
Do you know what fraction of your spend is in primary care?
We're single digits still. So we have a ramp. So we like these things. We will be ramping up the investment. And part of it is to the large group how do we put those investments in large group and calculate those? Because there's a lot of a black box underneath our top line payment to integrated groups.
And then have you talked about a lot of, I'm not sure I'd call them micro, but sort of building block, kind of changes. What does the macro story look like on, say, total cost of care or increases or comparison to your competitors? Does all this at the macro level, is there a reflection or is the macro kind of overwhelmed by other stuff?
Are you moving the market?
Are we what?
Are you moving the market?
We have a serious plan, like with detail to get to the target amount. That's what we will get to, and that we think that will be market leading. So we're on the path to do it. I would say we're at the inflection point of the big bold bets have not kicked in yet. So the investments have been made in pharmacy and in the friction, kind of the administrative. So we have made the initial investment. We have not reaped the benefits. So we've done the foundational work. I'd say our cost of healthcare, our pay-for-value models are working. We've got a pathway to scale them. We actually have 5 more in the pipeline to get us to that. We have a pathway to 100%. So I believe within the next 3 years, by 2028, our goal is to be at target and market leading. So that we believe it all fits together. We put these 3 things for a reason. The reason we put those huge bold bets is the last 2 things I showed you are going to be good, not good enough. That is our calculus of if we don't do those things, we will be market parity. If we do those things well, we will be market leading for a while until everyone gets to benefit from them, and we better then get better and do the next thing. So,
Peter, I think on your 2% pledge, one of the things the company did was invest in Manifest MedX, and you've been a big leader in data exchange. Would you give me a sense of how you think those 2 efforts are going?
Participation. We love the policy framework. We think it's super clear, and it has changed the conversation, I can say, in California. And I think we're sitting on data exchange where Blue Shield is sitting on some of our payment models, which is we've done the infrastructure work. We've got a constructive policy. We now need to take it to scale and deliver value, use case value off of that. I think there's good intention, and we're just in that messy middle is where I would describe it. So it is directionally, the moral arc is moving in the right direction of data sharing, and we need some more force behind it, I would say. It would be helpful to get more force behind the data sharing and encouraging it. And then I think see the market deliver value. It is direct. I mean, what I would say is all of our conversations with providers are incredibly constructive now. And thanks that we have a policy framework and a very clear set of what's expected. And it's now incumbent upon the combination to deliver on those use cases.
Great, thank you. There's nothing else from the board. I think we will take public comment. Thank you, Peter. Appreciate very much your presentation and the work Shield's doing. Thank you.
Thank you.
At this time, we'll take public comment. If you're in the room, please step to the podium. If you're online, please raise your hand. Please keep your comments limited to this agenda item and 2 minutes if possible. Looking to the podium, go ahead.
Beth Capel for Health Access California. I'd like to begin by acknowledging that part of the reason we're all here is because Blue Shield early on made a commitment to the concept of OCA that was based on if they weren't able to meet the targets, they would reduce their share of the medical loss ratio. And that is enshrined in the legislation that enables this whole effort. So I would be remiss if I did not acknowledge the role they played and also the many hours I spent sitting around a table with Andrew Kiefer trying to get us here. We have said in the past, with respect to the cost target and the other ambitious goals that OCA has, that we very much appreciate those who are trying to get there. And we have patience, both for the fact that it takes time and that there may be things that don't work, because that's what trying's about. You try things and some things work well and some things don't work as well as you hoped. So we would commend that spirit on the part of Blue Shield. Finally, I'd note we're very pleased to see the focus on equity here and in the earlier discussion about APMs. Equity is about race, ethnicity, language, disability, sexual orientation, and gender identity. It is also about income. And while we don't normally think about income because we rely on the segmentation of the market into Medicaid and commercial, in truth, the commercial market has a broad range of incomes within it. And we know how much that drives the social determinants of health. So as we think about this, we would encourage looking forward to think about how we bring income. And to those who say payers don't know what income is, employers do. They know what wages they pay their workers. And so that is a knowable thing. And it just as it's hard to do the race, ethnicity, language, disability, SOGI data, it is will be a challenge to do income, but it is part of the challenge that's ahead of us. Thank you.
Thank you. Looking virtually. Seeing no hands raised, looking back to the room. If you'd like to make a comment, please step to the podium. Seeing no one, that concludes public comment on this agenda item.
Great. Marguerite, ready to go?
Yes, great. Thank you. Thank you, Peter and the Blue Shield team for the presentation. And now I'd like to invite Carrie Heinrich, President and CEO, and John Beeman, Chief Financial Officer from Adventist Health, up to the podium to share their examples of cost-reducing strategies at Adventist Health. And welcome, Carrie and John, and we're happy to advance slides for you. Just let us know when.
Thank you. I want to thank members of the Office of Healthcare Affordability for the opportunity to address you and to provide some perspective on the context for Adventist Health and the work that we do in California, as well as Oregon and Hawaii and the state of Washington. We've presented slides, and I'm going to walk through the first couple of slides and then just spend time focusing on some key areas that are near and dear to my heart as we talk about the challenges of healthcare delivery in California. If you advance to the first and then second slide immediately, first slide is just our mission, why we do what we do. We're a not-for-profit organization. We serve in the communities we serve because we think it's important to serve. Let's move to the next slide. So I put this slide in so you'd have a sense of our footprint of where we physically serve. In Southern California, in the communities of Los Angeles, East Los Angeles, and Montebello, in Glendale and Simi Valley, then working up through 8 different hospitals and more than 300 clinics in the Central Valley of California, our most recent region that we have begun providing services in the Central Coast region with San Luis Obispo, then into Northern California and an important provider of services in the Mendocino and North Coast region of California. Next slide. There's some basic demographics here that I'm going to skip over very quickly. It just sets a little bit of context. Between our physicians and our employees, 38,000 people that are part of our organization, 28 hospitals, but the most important thing I want to focus on is the next item under hospitals, which is clinics, 442 clinics largely across California, many of those in Central California. And then the last number there, 2.7 million clinic visits. It's actually going to be well north of 3 million clinic visits this year. But all of that I just wanted to give you as context for the right-hand side of the screen, which is people served, which is where our heart is. You can see the breakdown of, we call this our payer mix. 2% uninsured, that's a complicated definition. 19% commercial insured, included within that would be products within the exchange, and then 79% of our patient base is governmental payers. The lion's share of that will be in the Medi-Cal space. Why is that significant in what I want to talk to you about today? And that is, I've listened to several of the presentations that have been made. Recently, Barry Arbuckle from Memorial Care spoke to you. He talked about the value of an integrated delivery system and the value of alternative payment models. I know Barry well, and I so appreciate what he had to say, and I could not have agreed with the points that he made more. But I want to now talk about, for Adventist Health, the space that we work in and the particular challenges we face as a system in providing care into the unique communities we serve. If you think about East Los Angeles, we've been there for more than 110 years, and that community has changed. But today, I think it would be fair to say it is reflective, that is East Los Angeles and parts of Montebello, as reflecting key spots of health disparities. And our campus at White Memorial is a special place because we provide hospital-based services to a whole variety of individuals within that immediate section of East Los Angeles, and care and access to care for people who otherwise would have very limited access, particularly to procedural services, interventional services, and hospital outpatient and inpatient services. And the same would be true for our hospital that we just acquired less than a year ago through the bankruptcy court process in Montebello, formerly Beverly Hospital, now Adventist Health Montebello. I start with those communities because they are indicative of these core concepts that I think you've heard a lot about, that being the value of an integrated delivery system, and coupled with that, utilization of alternative payment models to serve those populations. I'll also, in parallel with that, talk about the Central Valley of California, where we have 8 hospitals and more than 150 plus clinics in that immediate region. There are rural health clinics which vary from an FQHC clinic in that they qualify under a unique definition for rural health. Those clinics, together with our outpatient departments as part of our hospitals in the Central Valley, are clinics, hospital-based clinics in East LA, coupled with our hospitals, form the backbone of our integrated delivery system. The question is, though, in the core areas where there are demonstrated health disparities, how do you actually create a transition from fee-for-service medicine to an alternative payment model? Barry made the point to you about the value of right patient, right place, right time, right service level for that patient, and there is no question that's the right model we should be moving to. But the reason I'm focused on the Medi-Cal space, those with health disparities, is you're working with areas where there are very limited resources. I will tell you candidly, I don't have people lining up to partner with me to create ambulatory surgery centers or private equity lining up to partner with me in areas where we serve in rural California and inner cities because of our payer mix. And so when you think about alternative payment models and how you could create a different methodology of rendering that care, given the patient population that we serve, we focus on how can we make our outpatient hospital departments, existing facilities, existing assets, existing structures work in the context of an alternative payment model. There's no question we want to believe in and will encourage you to drive towards a different payment model. Currently, it is a very dysfunctional position for us, especially in rural California and inner city, when you have one foot in the old fee-for-service canoe and at the same time another foot in a new alternative payment model where you're taking risk, where you're starting to use your integrated delivery system to manage that patient population in an effective way, But the truth is, the way you manage those populations in two different payment models is very difficult. Why? Well, because in a fee-for-service model, we're reactive in how we render care. What do I mean by reactive? We're reactive to the patients that walk into our emergency department. We're reactive to patients who seek care in our outpatient departments. We're reactive to those who haven't established a relationship with us. They're fee-for-service Medi-Cal or Medicare, and they have choice, a good thing, but it limits our ability in that context to be able to actually manage those patients, create everything from access to primary care portals to how they will access care for specialty services, how we will manage them for purposes of access to procedural care, and of course then ultimately in some cases inpatient care. We do not have the ability within our system, integrated as it is, to actually manage that cohort of patients. That's a challenge, candidly, because on the one hand, you would want to be able to manage and oversee and drive very specific objectives, both from quality and from the standpoint of resource utilization. But the fee-for-service model limits our ability to actively engage and actively drive and actually direct patients in that context. Across California, we have about 165,000 Medi-Cal lives that we have, primarily in our Central California and Northern California regions, where we have an alternative payment model, where we have taken risk for that pool of patients. Now it is a very different picture for us. We can drive patients respectfully into defined primary care networks, a defined clinic structure. In that structure, we can choreograph both their specialty care as necessary. We can choreograph virtual visits for those patients. We can focus on what their specific needs are and actually do the process of managing that care. We can also make very specific decisions virtually about accessing behavioral health, real-time access to that behavioral health, real-time access virtually with specialty care. Again, we cannot do that. We're very limited in our ability to do that in a fee-for-service structure because we don't have the ability to actually manage and choreograph or structure the delivery system for those patients. So particularly in the Medi-Cal space, I want to call out Medi-Cal health plans who have partnered with us in a very real way to develop a mechanism to start defining enrollment, defining our process for taking responsibility for a pool of patients. Our greatest challenge, candidly, is having enough enrolled lives to make it actuarially sound. What do I mean by that? Well, it's pretty straightforward. You have to have the ability, if you're going to take risk for a pool of patients, to have enough patients to actuarially spread the risk that you have assumed, and you can't do that with small numbers. You can't do that in 3 or 5 or 10,000 patients. You need a broad grouping of patients to actually absorb the risk actuarially and then be able to manage in a cohesive and coherent fashion that risk. So, my encouragement to you, and I know I'm limited and virtually out of time here, is to continue the journey of helping us in a planned fashion work towards alternative payment models that allow us to take responsibility for a pool of patients, a defined grouping of patients, then build out structures in an integrated delivery structure fashion to manage those patients. I happen to believe that is the most realistic way that we can engage and provide quality care, quality health care that we can actually track and see the results of the process we are putting in place, and actually be able to demonstrate cost savings as we align our incentives to reduce unnecessary emergency room visits, reduce other factors that unnecessarily drive up the cost of health care. I'm going to pause now and let my colleague, our Chief Financial Officer, John Beeman, talk to you for a few moments about things as a system we have done and continue to do to drive down core administrative and overhead cost structures that allow us to be more effective, more efficient in driving the dollars that we have available to actual patient care delivery, which is our goal, which is why we do what we do. You should know every dollar of margin, we don't call it profit, it's margin that we generate in the not-for-profit space. We invest all of that right back into the communities where we serve. We think that's our responsibility, to take dollars that are generated and fully invest them back in expansion of services, expansion of equipment, updating facilities, driving recruitment and retention of key physician providers. I'll leave you with this. One of the things I'm proudest of our company is the work that we have done to expand residency programs in family medicine, internal medicine, obstetrical care, pediatrics. All of that driven with a core focus on recruitment of physicians out of medical school that have ties to East Los Angeles, the Central Valley, Northern California, because we have learned over many years of doing this that recruiting medical students who have ties family-wise or other heritage connections to geographies where we serve, we have our best chance of retaining them. In the Central Valley, we have more than 60 residents. We believe we'll retain most of those year over year in expanded funding programs to serve right back into those communities. That's our commitment. That's our focus of growing that primary care side of our equation through our residency programs. John, talk about what we're doing on the overhead and administrative side.
Thank you. If we go to the next slide, I'm going to build off of where Carrie ended. Around, as we're able to either aggregate lives or aggregate scale, how do we actually use that to have the most efficient cost structure to put more care to the patient and also more dedicated expertise? Because I think those are really the two value mechanisms and they go hand in hand. And so, first of all, how we think about scale is the ability to aggregate spend, aggregate capabilities to serve a broader population. So again, building up what Carrie just said, if you think about a broader base of lives that we take responsibility for, how do we then bring expertise and use that expertise across that broader population? In many cases, the expertise needed to manage, say, 10,000 lives is going to be very similar to some of the expertise to manage 150,000 lives. And that's part of how we've been able over time, and we'll get to that on the next slide, take our administrative costs to a lower portion. Give you a quick example. Our compensation department for employees across our system is 4 people. If you think about it, if we were a standalone hospital, we probably would have 4 people to manage that all by itself. And so we're able to leverage that expertise across a broader employee base, thus reducing our administrative costs and having more opportunity to fund patient care. And so you see the 2 buckets here that are on the slide, administrative costs and clinical care. I'm going to go to clinical care first and then go to administrative costs to tie into Carrie. So in clinical care, the systematic review and implementation of standards, so having dedicated clinical expertise. Again, if we determine what is the best clinical pathway for a certain diagnosis, we can replicate that across our system. It's a speed, it's a best clinical value. Same thing on the quality programs are the same. And again, as Carrie noted, it gives us a broader ability to manage risk-based responsibly. On the admin side, it really does become how do we have dedicated centers of expertise for certain functions and become more efficient in our delivery of those services. If we go to the next slide, this is where I think you've seen this in the material. Actually, go one more slide. This is where the trend that we've been on, where 3 years ago, we were at a 14%. But as we become more efficient, the previous slide mentioned automation. It mentioned able to remove waste from our systems. We've been able to reduce our spend now to under 10%. We want our goal to get to 7% by 2027. Each moment of efficiency, each process that we redesign across our entire footprint enables us to be focused where our focus needs to be, and that's on the care for the people in our communities. And so as we look at this, we see more and more opportunities in the future. We've just touched the surface on automation. There's other opportunities. I'm going to get granular for a second. Think an AP invoice, right? It's possible to say someone sends you an invoice and have 0 touches all the way to payment, right? Versus having it handed from one person to another person or one process step to another. I know that's a very probably non-exciting example, but it is the reality of what we mean by how do we become more efficient and give us the opportunity either to automate some of those processes or just simply find ways to leverage our current structure across a broader span. So as we've grown, Carrie talked about our new service areas, the growth we've had. We've been intentional about keeping our current staffing in place, but how do we now use that same staff to serve more people? And to me, that's a great example of both fulfilling our commitment to the people who have worked with us and maintain our commitment to our communities of being affordable in our delivery of care. So I was going to land there. I know we have limited time, but wanted to give you some very specifics around what we mean by administrative cost efficiencies and how connecting to Carrie's commitment on how we manage for people and care for people under multiple reimbursement arrangements. How does our ability to aggregate that enable lower cost of care?
Thank you, Carrie. Appreciate that. I'll open up comments, questions from the board. Well, maybe I'll start. Carrie, you mentioned, and I know Hector Floyd as well, and so I know all the good training you've done of residents, and you mentioned this program in the Central Valley, and I'm curious, maybe sharing a little bit about the partnerships you've had to kind of grow the primary care workforce and to be able to do the kind of training that you're doing for our workforce, which is one of our next topics on the agenda. And so I'm curious to know how you've built out that infrastructure.
So it's no surprise to you that we have an enormous set of challenges, not just in California, but across the country in physician staffing. Several people who have presented, because I've listened to their presentations, have talked specific numbers. Anesthesia, the cost of anesthesia coverage, the cost of a primary care physician. We employ many primary care physicians within our physician foundation structure, but we lose dollars in that regard, but it's an investment we're making as a system to grow that access point in the communities that we serve. How do we do that? I hope I'm answering your question here, but I believe we can only do that given the realities of staffing by growing them ourselves. That's why in East Los Angeles, in the Central Valley, in other parts of our system, we have grown and expanded residency programs with a very specific focus on recruiting physicians out of medical school that have ties to a given community. That's how you keep them there. You bring somebody in for their residency program, they get their training, and they immediately leave. And we feel good about expanding the physician workforce, but it does not help us to serve our communities given physician staffing shortages. So our focus has been look for specifically recruitment of physicians that we think we have a high probability of keeping in the geographic region where we need them most. And that's certainly inner city, rural California, certainly central and northern California as well.
Thank you. Anybody else? Rick?
Rick, can you push again?
Thank you for the presentation. You mentioned, Carrie, I think that you talked about the sort of virtues of APMs and the vices of fee-for-service, and I think mentioned that you had 165,000 members in sort of not fee-for-service. What fraction of your total patient base is that?
John, help me out, but I guess it's less than 10%.
About 10%.
Not near enough. If we got to a point where we were north of 50%, you'd have enough scale actuarially to begin using some of the dollars generated through that alternative payment model to invest in specific ambulatory facilities where I'm not going to get venture capitalists to join us in East Los Angeles or some of the rural communities, but then we would take those dollars and immediately reinvest them right back in so that we had a less intense setting, such as an ambulatory surgery
If I
center.
can just follow up briefly, you also showed that 79% of your business is government funded, mostly I assume Medicare and Medi-Cal.
Right.
Way over half of Medicare patients in California are in Medicare Advantage. Almost all of Medi-Cal is in Medi-Cal managed care. But they're paying you regular fee for service, or how? I'm a little confused.
It's a split structure, and I'll let John speak to that. In many cases, those Medi-Cal or Medicare managed care lives may be capitated to an independent physician practice structure or other outside structure, not capitated directly to us. So even though they are capitated on the professional side to a physician group, the health plan may hold back the hospital side of it. So even though the patient is under a capitated structure, we end up being paid on a fee-for-service basis, and that defeats much of the purpose of trying to fully manage, both on the professional and the institutional side, the care of that patient. Without doing it in an integrated fashion, you lose so much of the benefit of an alternative payment model when you split it. John?
No, Carrie answered it well. We are still paid in most of those cases on a fee-for-service environment, even though the overall program has a managed aspect to it. As Carrie said, what we're suggesting, including us in that management, that partnership, we believe there's additional value to doing that.
Just to follow on to that question, are any of the health plans that you're working with moving in the direction that you'd like to see?
Yes, I'd just like to see it faster.
Okay, thank you very much for your presentation and the work that you're doing and the populations that you serve and taking the amount of government funding that you're taking to do your program. So thank you very much.
Thank you. Honored to have a chance to present to you. Thank you for the work that you're doing.
Great. Okay, I think we need to take public comment on this item as well.
We'll now move to public comment. You can step to the podium if you're in the room. Raise your hand if you're attending virtually. Seeing no hands raised, noting we have about 90 attendees virtually, seeing no one at the podium. That concludes public comment on this item.
Okay. Who am I giving this to? Michelle, to you? To Margaretta. Okay, Margaretta. Workforce stability, I think.
Yes, thank you. So in this next portion of the agenda, we will turn to the workforce stability standards and provide an update on where we are and provide an overview of the changes we've made to the workforce stability standards based on our presentation to the April board meeting. So as a refresher, I just wanted to start here in terms of statute. So, and then, sorry, before I move to statute, did also want to note that hopefully we'll have in person joining us today, Joanne Spetz from the Institute for Health Policy Studies and Health Force Center at UCSF, who can help answer questions from the board. So apologies, I wanted to note that. So just as we start usually with an overview of our statute, just a quick refresher that the statute mandates that by July of 2024, OCA develop standards in consultation with the board to advance the stability of the healthcare workforce, and these non-enforceable standards will be used to monitor workforce trends and promote stability as the spending targets are implemented. And then additionally, the statute also notes that OCA may require a healthcare entity to implement a performance improvement plan if spending targets are not met, and the board must approve workforce stability standards that apply in an entity's performance improvement plan. So currently our focus is on developing the general standards mentioned on the previous slide, but these general standards will be used to inform the standards used in a performance improvement plan, and we will come back to the board with more discussion on that as we move towards progressive enforcement efforts. So I won't review this slide in detail as we covered most of this in April, and so today we will focus on a review of the workforce stability standards that OCA has adopted and considerations for future data collection. And as a refresher again on our approach to the workforce stability standards, we are framing the workforce stability standards as best practices that we are strongly encouraging organizations to implement these standards, including monitoring a set of key performance indicators to assess their effectiveness in achieving a stable workforce. And while there are no financial penalties for non-compliance, as I noted earlier, that these standards may be used to inform the development of standards that apply in a performance improvement plan for entities not meeting the spending growth targets. And we are currently proposing a monitoring approach that relies on publicly reported metrics to provide insight into workforce stability at the organization and market levels. And OCA will report on these workforce stability metrics in its annual reports. And we are also developing, based on your feedback and feedback from stakeholders and public comment, developing an approach to collect new data from healthcare entities on key performance indicators to enhance our existing public reporting, and may introduce performance expectations in future years after establishing baseline data. So in this next section, I'll review the feedback we've received from the board and the public comments on our proposed workforce stability standards and metrics, and then share with you our proposed final standards. So at the April board meeting, we presented an updated draft of the workforce stability standards that incorporated feedback we received from workforce experts, from stakeholder interviews, surveys, and advisory committee members. And we published a draft of the standards for public comment. So I'll share the feedback themes of public comments and the feedback themes you all had that guided further refinements to the standards and the metrics. So a few key themes here. So we've identified several overarching themes, which I'll summarize in these next few slides. So for the 6 standards we proposed, stakeholders highlighted the importance of measuring organizations' performance against the standards and requested more specificity. Multiple stakeholders also recommended that OCA include the physician workforce in the standards, and some suggested that we analyze the impact of workforce stability on continuity of care. So in response, we've refined the standards to improve clarity and specificity and ensure that our metrics are informed by the standards and the statutory requirements. And we will collaborate with the Office of Health Workforce Development to better understand trends in physician workforce, such as trends in the numbers of physicians per specialty per region. And additionally, we included more details on the relationship between workforce stability and continuity of care in our workforce stability standards document that was published along with the board materials. We also, on this next set of feedback, we received a variety of feedback on the key performance indicators that we've proposed under Standard 1. So those include indicators like turnover and retention rate. So opinions varied here on whether reporting performance on these KPIs should be mandatory for entities, with some strongly advocating for mandatory reporting, while others supported relying on publicly available data. There was also a recommendation to expand reporting on contract labor use, especially in behavioral health. And there was widespread agreement that turnover and retention rates are important indicators of workforce stability. And we heard that a recommendation to monitor a concise set of actionable metrics and measure real-time indicators of organization performance. So in response, we are proposing to collect new data on high priority key performance indicators, including turnover, retention, vacancy rates, and contract labor use. And we're exploring incorporating these KPIs into existing HCI data collection processes especially for hospitals and long-term care facilities. And then we're also investigating options for developing new data collection mechanisms to broaden the scope of entities reporting workforce data to include more ambulatory care settings. So this data collection and reporting processes and development will take time, and we're currently working across HCI to develop that. And then wanted to note, after 2027, under SB 779, we'll have a number of, we'll have more information on the number of contracted and total employees for licensed clinics. So that's currently a data expansion process underway. So another set of key themes here on our organization and market level metrics that we proposed in April. There were suggestions, again, to include and expand our monitoring of ambulatory care settings, particularly in behavioral health. Stakeholders also emphasize the importance of monitoring worker safety and reporting on mass layoffs. And we also heard recommendations for monitoring the availability of linguistically concordant care in the regional healthcare workforce. We also heard a number of suggestions for monitoring additional external data sources, such as the DMHC and DHCS network adequacy reports, data from the Employment Development Department and Franchise Tax Board and IRS. So we are actively exploring options to address data gaps in ambulatory care settings. We are also examining external data sources that can enable us to monitor worker safety and layoffs and important measures of worker stability. So we are in discussion with several of these departments and organizations to learn more about the data they have, how they report it, how we might be able to access it more quickly, and we've had a few of those conversations. Wanted to note our existing public data sources provide information about languages spoken, race, ethnicity of licensed providers, and that many of our metrics can be analyzed by geographic region. And then we are also beginning our work to develop a reporting structure that will enable us to track the relationship between spending, target performance, and workforce stability. So we appreciate the feedback on all of these metrics and the wide range of perspectives on both of our standards and metrics, and want to emphasize that these standards are a starting point and that we will be building on them over time, both as we continue to work on the standards and continue to work on additional data collection efforts. So one note from the board meeting in April, the board asked for more information about the relationship between workforce stability and healthcare spending. So wanted to note that our published workforce stability standards document highlights the importance of recognizing healthcare workforce as an asset in meeting the spending targets. There is research and data to show that investments in well-trained and well-compensated workforce can reduce staff turnover, can mitigate burnout, and decrease reliance on contract labor. For instance, recent research in both US and other countries has shown that investing in hospital nursing staff can generate net savings by reducing adverse events, shortening lengths of stay, and lowering readmission rates. We also note that rapid wage increases resulting from use of contract labor can strain budgets and create pressure to reduce staffing, and that maintaining and promoting a stable healthcare workforce requires investing in new employees and retaining existing staff. So wanted to share that research and connection based on our the work we've done with UCSF and the research that they have done. So here, in these next 3 slides, I'll review our 6 standards for ensuring workforce stability in the context of the spending targets and highlight the changes we've made based on board and public comment feedback since April. So in this first standard, we're not proposing any changes here. This standard directs healthcare entities to monitor these key performance indicators, such as turnover and retention rates and time to fill vacant positions. And as I noted, OCA is developing a process to collect some of these data in future years. And here are standards 2, 3, and 4. And these standards include developing formal processes to adapt to changing workforce conditions, allocating resources for professional development for healthcare workers, and increasing the use of interdisciplinary healthcare teams. And here the green text indicates revisions made in response to board and public comment feedback on the April 2024 draft standards, which I summarized that feedback earlier, and these are the proposed revisions. And again, and here are standards 5 and 6, which prioritize hiring, employee advancement, and care delivery practices to provide culturally and linguistically competent care, and finally, monitoring and addressing workplace safety and violence. So these are our proposed 6 standards for OCA to adopt, and we are aiming to adopt them this month and finalize them this month, and OCA will be publishing the final standards. We published the memo with the standards and all of our detailed background and rationale on our website, along with the board materials. And then to turn to our metrics. So as a reminder, we plan to monitor workforce stability at 2 distinct levels, at the organizational level and at the labor market level, and using a variety of publicly available data. And on this slide, we just summarized and provided examples of the types of metrics that we'll monitor at each level. So we plan to track wages and benefits, workforce composition, and staffing intensity at the organization level. And then at the labor market level, we will monitor metrics that inform the overall functioning of the healthcare market within or across various occupations and regions, including demographics, employment information, and training. And the complete set of organization and market level metrics are in your appendix and also in the document published along with the board materials. We shared this in April, but just wanted to provide a quick overview of accountability for the workforce standards. So although these are framed as best practices, there are several avenues for healthcare entities to be held accountable for their success in achieving workforce stability. So OCA's public reporting of the organization level metrics will provide detailed information about wages and benefits, workforce composition, and staffing intensity. And baseline data is currently being collected for the publicly available metrics alongside our work to implement future data collection. And this data will allow OCA to consider establishing performance expectations for entities on the key performance indicators and other organization level metrics. And lastly, for the performance improvement plans, here, as we come back to as we work towards progressive enforcement, we will be developing workforce stability standards that apply in a performance improvement plan and are informed by these standards and key performance indicators. So we heard feedback both from the board and numerous stakeholders requesting that we mandate reporting by entities on the workforce stability standards. And as I noted earlier, we are assessing options for adding new data elements to existing HCI data collection mechanisms to include high priority key performance indicators. And we're collaborating across HCI to conduct this evaluation and investigating regulatory and data analytic requirements. And then we're also exploring several of the recommended external data sources. So you all suggested several data sources that we are currently and actively reviewing, and The details of each of those data sources that have been recommended and our planned approach to investigating each source is in the appendix. And wanted to note, in some cases, those external data sources require a data use agreement or substantial resources to extract and analyze the data. So we are meeting with those external organizations and agencies to explore what that would look like. And as I noted previously, due to the complexity of that evaluation and potential new data collection, our initial workforce stability standards do not include any of these new data sources, and we'll provide an update to the board and the advisory committee on our learnings and progress by fall of 2024. And again, these next 3 slides, just to wrap up, provide essentially clean versions of our workforce stability standards. So again, these are proposed and recommended that OCA adopts these standards as a set of best practices to ensure workforce stability within organizations. And I won't describe the standards again, but we just wanted to share the final version of the standards that OCA has adopted. So this is standard 1. And again, these are standards 2, 3, and 4, just in a clean version, and standard 5 and 6. And just to wrap up, so now that we have finalized our workforce stability standards, over the next several months, our focus will be on investigating new data collection opportunities and planning for future reporting. And we'll, as I noted, update the advisory committee and the board this fall on our progress in these areas. And with that, I'd like to open it up for discussion and feedback from the board, especially on any feedback for our proposed planning for organization level data collection on the key performance indicators.
David?
Well, once again, Margareta, thank you very much for a very complex and comprehensive presentation. I actually don't have a question. I just wanted to say that I think I was looking at all the standards and trying to find opportunities to enhance or buff them further or add things to them, and I was coming up short. So I think you've covered everything that I could think of in this regard.
Ian?
Likewise, Margareta, I think these changes really strengthen the thing. Do appreciate all the work you put into it. A member of the public commented that this is a board paraphrasing, but that we're learning as we go here. And I very much see this as another case study in that. I look forward to the day when we can set standards that are actually metrics, given that right now we're in the phase where we have to gather those metrics and take stock of what the reality is out there. And I think this does a good crack at getting there. Thank you.
Rick, anything?
Thank you. I add my thanks. And I am reminded of our vice chair's constant refrain that a big part of the value of OCA's work will be increased transparency. And I look forward to the fall of 2024, which is relatively soon. I am a bit dismayed is too strong, dissatisfied that what we have in front of us right now, as I understand it, will add very little to increased transparency. And I understand everything takes time. And the fall is pretty soon, and I'm hopeful that when the fall comes, we will have a greater line of sight towards increased transparency and more information than we have now.
Yes, so I will maybe just pile on with my colleagues and say that, nobody to my knowledge in other states have developed workforce stability standards or mechanisms for reporting. And so we really are cutting new ground here and leading new ground. And so I just really want to compliment the team for diving into what is a really complex issue and so important to everything that we're trying to achieve as well. So Thank you to the team and to your consultants for this work. And I too really look forward to the day when we will have some data that we can share publicly on this. With that, unless there's anything else from the board. One other thing on the physician piece, much as we have heard on cost control and quality efforts from providers and plans, there are efforts in the state to really address some of the significant cultural and linguistic gaps we have in the physician workforce. And at some point in time, it might be helpful to shed some light on the work that's going on in the state to address those significant gaps that we know exist now. And so maybe we put a pin in that, not to expand your workload any, but I think it'd be an interesting topic. So thank you.
As you know, Dr. Hernandez, we have the Workforce Research Data Center here at HCI under our workforce team, and they are doing a lot around. Of course, all of our workforce efforts are designed to diversify to increase the linguistic and cultural racial diversity of the workforce. And so we do have some good data there, and I think they would welcome the opportunity to present some of that data.
That'd be great. I think that'd be great. Okay, I suspect we should take public comment on this item. Yeah.
If you'd like to make comment, please step to the podium. Looking online, seeing one hand raised, we'll start there. Can you tell me the name? Harvey, we see your hand raised. Go ahead. Harvey, you're unmuted on our end.
Hello, can you hear me?
Yes, we can hear you. It's a little muffled.
Okay, well, sorry if it's muffled. Harvey Jones, Carpenters Union. Really appreciate today's discussion.
Harvey, I don't think we can hear you. Harvey, we'll give you a moment. We'll switch to the individual at the podium, and we'll come back to you in just one moment. At the podium, go ahead.
Beth Capel for Health Access California. We very much appreciate the spirit of the workforce stability targets and the data collection. We particularly commend what I think is slide 85, it's a little hard to see the numbers, on the recognizing the research that a stable healthcare workforce is an asset rather than a cost center, which is consistent with our understanding for decades of the research in hospital staffing and nursing home staffing. We would also commend having mandatory data collection in this area as we have for every other standard. The reason this is here, along with the quality and equity measures and the other pieces, is to make sure we're not cutting cost at the expense of the workforce, but also because of a recognition, a very foundational recognition, that a stable workforce was important to assuring quality of care and outcomes. So thank you.
Thank you. All right, going back to Harvey, you're unmuted. Harvey, we can't hear you on this end. We will move now to Joan Allen, attending virtually. Joan, go ahead.
Can you hear me?
We can.
Great. Thank you for the update on this. Joan Allen with SEIU United Healthcare Workers. And we really appreciate the ongoing work and the progress that this version of the Workforce Stability Standards represents. Very glad to hear the progress on new data collection efforts and the work that will be done to incorporate data from the existing sources, particularly the EDD and WARN data. The sooner that we can move forward with that work, the sooner we can get to that baseline reporting that will then lead us toward that accountability through the performance expectations and the transparency. Just want to echo the board's eagerness that we get to the fall and we get to that next step, but do just appreciate the recognition of workers as a benefit to the system and the need to protect workforce stability, and see this version and these standards as that next move forward, but with the recognition that this is an interim state, not the final version of standards that actually gets us to being able to protect workforce stability. So just so much appreciation for the work that's been done and looking forward to that next stage.
Thank you. Harvey, we'll give you another opportunity. Is he unmuted? Harvey, we're unable to hear you. I apologize. But you do have an opportunity to make a public comment at the end of the meeting also, if you'd like to try and join us maybe by phone at that time. All right, that concludes public comment on this item.
Okay, thank you, I appreciate that. Okay, cost and market impact review draft regulation revisions. Sheila?
Good afternoon.
Sheila, welcome.
Thank you. So we'll go over the proposed revisions this afternoon, and as Deputy Director Pagani mentioned this morning, our team has responded to over 50 emails to our CMIR inbox, probably picking up the activity. It didn't start right in January, but it probably started in March. And so we welcome the use of that email inbox. It's helpful to us, it's helpful to our regulated public, and we try to turn those responses around in a very timely fashion. We try to respond within 48 hours, just so we keep things moving. And we've also invited people who sent emails, to ask us further questions, or if they feel a discussion is necessary. We have met on virtual meetings over Teams with several entities who've asked questions, because we think this is helpful. We want to be helpful to our regulated public. So with that, I'm going to go over the proposed revisions, because most of these revisions came out of these questions, these questions and answers that were coming from our regulated public. So at a high level, there's not that many, but starting with the definition of affiliation, we removed affiliate from that because there was confusion over this definition and the use of the word affiliate when calculating revenue and including affiliates in that revenue calculation. Secondly, we removed the date of April 1st, 2024 for notifying us of material change transactions, because it's past April 1st, 2024, and so that's no longer relevant. Now, one of the bigger changes that we've made is who must file a material change notice, and I will go over that in more detail when we get to that specific slide, because it is an important change based on what we were observing and what we've heard in industry, and we really do want to make this clear. We also made an important change to adding fully integrated delivery system. It was not intended to leave them out whenever we use the words payer or provider. It wasn't followed by fully integrated delivery system, and it should have been, because healthcare entities under our statute are defined as payers, providers, and fully integrated delivery systems. So we just added that term as appropriate whenever we're talking about healthcare entities. And then we made a change to the health professional shortage area, and this was really to clarify what we intended by that. We're really looking at an entity that provides services in a health professional shortage area. I'm going actually into the details, so we'll get to that when we get to that slide. Also, there's a reasonable diligence attestation. We made changes to the request for confidentiality that we think will help our regulated public. We put something back in that was originally in our regulations on the ability to meet its spending target as part of one of the factors for determining whether to conduct a CMIR. And then throughout, we've made non-substantive grammatical changes, which is very common when you're going through the regulation process, and probably even more common when you're going through the emergency regulation process. So as I said, going to the next slide, let's see if I can do this from here. It works. So we removed the parenthetical affiliate in 97431 because that was confusing some folks because they thought that was part of the calculation. They were confusing it with the calculation for revenue because our revenue is calculated based on the entity and all of its affiliates. So they were saying, should we use this definition for affiliate when calculating revenue? We said, no, that wasn't our intent. So we decided, let's take this out because this is confusing. I'm seeing nodding heads, so I think people are comprehending that. So, and as I mentioned, the next one was the removal of the date of April 1st, 2024, no longer needed. And then here we go to, let's see. Oh, went too far. There's a little bit of delay. Here we go. All right, who must file? Let me give you a minute to look at this one because it is a pretty text-heavy slide. So I'd like to start with B3, which is the HPSA threshold requirement. So we clarified that to show that it's a provider or fully integrated delivery system that is a party to or subject of the transaction and provides healthcare services in a designated primary care health professional shortage area, HPSA. The providing healthcare services in a HPSA was the important change there because we were getting questions from people who said, oh, we have an office in a HPSA. We have a corporate headquarters in a HPSA. Do we need to file? And we said, no, that really wasn't the intent. And I should say that whenever we answer these questions too, we always tell the folks asking questions, we can't give you legal advice, but we will answer the questions the best we can and meet with you and discuss. But if you have legal interpretation questions, talk to your attorney. But that one was pretty much, this is clear. We're talking about healthcare services performed in a HPSA. All right, now let me go back to the top of this, the other change, where we added or a subject of. So you'll see who must file, a healthcare entity who is a party to or a subject of. So what we're seeing in these transactions, which can be very complex and multi-layered, is that the healthcare entity whose assets or control is being transferred isn't always a party to the transaction. It could be a parent that's transferring control of that organization. It could be an affiliate. The entity itself, whose assets or control is being transferred, isn't always a direct party to the transaction. So we made this change to include when the entity is the subject of a transaction, because that really aligns with our statute, because our statute says a healthcare entity must notify OCA when there's a material change of ownership, operations, assets. That's the requirement. That is the statutory requirement to notify OCA. So regardless of whether you are a party to the transaction, if that transaction is transferring your control, operations, assets in a material way, notice is required. So we really feel this change aligns more closely with the statute, which we tried to do in a different way the first time around, but we're trying a different way to make it clear to people this is how you meet the statutory requirement. Because if the transaction is doing this to your organization, you need to tell us, okay? So we think that this will help our regulated public understand. And to give you an example where we're seeing this happen, the skilled nursing facility industry is, I would say, somewhat consolidated. Some would probably say even more so consolidated because there are large national players that own multiple skilled nursing facilities across the country. They may be doing something with a smaller entity in California somewhere, and that entity won't be a party to the transaction, but the actual control and operations of that entity is being transferred. And so that's an example of where we see situations where the entity whose assets or operations is actually being transferred is not a party to the transaction. So I'm going to go ahead just a little bit because I don't have too many slides, but I wanted to talk about the comments that we received. Wait for the delay here. Maybe my staff can help me get to the slide on how many comments we got. There we go. So we posted these draft revisions and comment was due June 20th. So that was just last Thursday. So at the time we went to press with these materials, we did not give you a written summary of what they were. So I just want to tell you about them while I'm presenting today, so you do get a flavor of what the comments were. So we received 6 written public comment letters by the June 20th date, and they were submitted by a law firm, provider organization, and various associations. So going back to the slide I was talking about changing the HPSA and being a subject of a transaction. One more. There we go. So there was some concern expressed in one of the comment letters that this was going to vastly expand the number, maybe it was even more than one comment letter, vastly expand the number of notices that we would receive. But I wanted to clarify that in order to have to be the one who notices, you still have to be a healthcare entity. So first you have to determine under the statute, are you a healthcare entity within the definition? And then you have to meet the thresholds, right? So then if you're a healthcare entity, do you meet the monetary thresholds and regulations or the geographic threshold, which is the HPSA? And then finally, does your proposed transaction meet the circumstances? I think there might have been some confusion that this was going to mean that everybody in the transaction or everybody related to somebody in the transaction would have to file. And that's really not the case. You have to go through those elements first as to whether you have to file. Are you a healthcare entity? Do you meet the thresholds? Does the transaction meet the circumstances? So it's not vastly expanding the number of filers that need to file with us. And I hope, I'm seeing again nodding heads, so I'm glad to see that. All right. So next slide. Thank you. So we wanted to clarify revenue because revenue is used in a couple different places in our regulation. As I mentioned, revenue is part of the calculation of, are you a healthcare entity that meets the threshold revenues for filing with us? All right. Then in our circumstances, we have some circumstances that relate to projected revenue. For example, if the transaction will result in a formation of a new entity that will have a certain amount of revenue by normal operating standards or normal operating. So, for example, number 5, the transaction will result in an entity contracting with payers on behalf of consolidated or combined providers and is more likely than not to increase the annual California-derived revenue. I'm going to keep going by either 10 million or 20% or more. So there was confusion about how to calculate revenue for purposes of the threshold, meeting the threshold. Was it the same as meeting revenue in the circumstances? And we've been saying, no, it's a little bit different because when you're looking at your revenue for whether you meet the threshold standards, you're looking at your affiliates, you're looking at all California-derived revenue. When we get to the circumstances, it's revenue as far as the plain meaning. How much revenue do you project to make based on this transaction? Okay. All right, next slide. All right, we added a reasonable diligence attestation, and there were some comments on this, I will tell you that. So we were getting some responses that we just don't know about the other entities. We don't know. We don't know. We thought, well, this is a material change transaction that you're giving us notice of. Wouldn't you want to know? So I don't know is kind of an interesting answer to receive when you're asking when the regulator's asking about the other parties. So we added an attestation requirement that the entity filing notice with us needs to exercise reasonable diligence in trying to find out that information. It's fine if they've tried to find out about it and they still don't know, but an initial response of I don't know doesn't help either the regulator or the entity that wants their transaction to go through review quickly to get the review done. So We hope and we believe that this attestation will be helpful to all sides. But again, as I said, there are some comments that were not in favor of this because it is an attestation that they have done so. And then you'll see, go ahead to the next slide. You'll see where they have indicated, well, the revisions have indicated where we've added a fully integrated delivery system. And as I mentioned, we were just adding a fully integrated delivery system whenever there was payer or provider. And then we were consistent in adding the language, the subject of, to each of the relevant areas where we talked about a transaction. So you were either a party to or the subject of. And one thing to be aware of is some of the comments felt that subject of, and then our definition of what that meant to be, what the definition of being a subject of a transaction wasn't clear. Some gave us proposed language, and we will consider those comments about whether they felt this was clear, whether they felt it was understandable, look at their suggested language and evaluate that. That's what the whole regulatory process is. This is why we go through a draft with public comment, and we take the time to consider and review these comments and see if we think the changes are appropriate. Okay. The request for confidentiality, commenters like this because we made it clear that if somebody asks for an expedited review, they can request confidentiality for that, because you can understand there may be circumstances where somebody needs expedited review, but they don't really want the public to be made aware of that. And then they can do so through our portal. And then this was an important addition. If OCA denies their request for confidentiality, they can withdraw that request and any information that they've submitted. And we received comments of appreciation for that, because somebody's saying, we want you to treat this confidentially, and then they answer no, they likely want to say, okay, we need to take that back. All right, next slide. Oh, that's okay. I was trying from here, but keep going. We're on to the decision to conduct CMIR. Let me see if I can go back. There we go. Thank you. That's okay. So we put this back in. We originally had this in our packet that went to OAL, but on including the ability to meet any healthcare cost targets established by the board, at the time we submitted that, the board had not set the cost target, right? So we put this back in our second packet because thankfully the board has set the cost target. So this really does align with the statute. You notice that I've included in the slide the statutory language, right? Commenters have suggested that it's too soon to do this, it's not fair to do this, because the cost target is not enforceable. Just want to neutrally deliver that message for our commenters. But again, this does tie to the statute, and the cost target has been established. Okay, next slide. I already mentioned that we received 6 letters, and I've gone over the theme of those comments with you, and I'm sure we'll hear from some folks today. And then last is our timeline. Thank you. So here's our projected timeline, and these dates could be sooner or later. So we posted the draft revisions online. We received comments by June 20th. We're projecting that we will post the notice for emergency rulemaking on August 6th. Again, that could be sooner or it could be later. That begins the official comment period on the draft text that we would send to the Office of Administrative Law. And then we would send to the Office of Administrative Law the entire packet with a projected approval of September 3rd, 2024. And those regulations would take effect. So again, I'll say one more time, these could be sooner or these could be later. And with that, I welcome your feedback.
Great. I'll open it up for the board. Any questions or comments? So I would just, Rick, please.
I have a question actually not about these revisions, but back to Vishal's earlier presentation. So I don't know if you want to.
Well, let's finish with this piece first, if we could. Anything, Ian?
Yeah, I'd say, I think the volume and the turnaround on the submissions so far demonstrate that, this office is taking this very seriously and quite capable of implementing what we've done. I think, this is another signal that we're taking them seriously as entities need to. I did trip up for a moment with concern about the confidentiality provision, but I think you're being appropriately balanced. So these look great to me.
Great, Sheila. I just had the question on this reasonable attestation language that we added, and I'm curious how that gets defined, reasonableness. That's something that they're attesting to. Does that have some legal underpinnings? How does that get adjudicated?
It does. Reasonable is one of those words in the law that gets challenged all the time. So these notices are submitted under penalty of perjury. So that's the attestation. So once they submit, they're saying, I'm submitting under penalty of perjury that I have reasonably tried to find out about the other entities in my transaction. But yes, there's a legal standard, and I won't go into all of it because there's a reasonableness in lots of different areas of law. So I hope I'm answering your question.
You are.
Yeah,
that
we
was
would
good.
probably we would say in our minds what we think reasonableness is based on the legal standard. That might be contested. That could eventually be litigated. But reasonable is a term that many attorneys understand, or at least know how to interpret for their clients. And we find that attorneys are the ones who are submitting on behalf of healthcare entities.
Great. Well, I just add to Ian's comment that I think you've done a really nice job of taking the feedback, hearing what needed to be clarified, and making the proposed revisions that you've gone through today. So thank you for that. Appreciate it. There's nothing else from the board. Oh, yes, Rick, sorry.
I support the proposed revisions. I have no problems with those. A sort of belated follow-up on Vishal's earlier presentation that there have been 3 CMIRs filed to date. And I wonder, I am surprised by that low volume. I remember hearing from Michael Baylett the number in Massachusetts, and we multiplied that by 7 because we're 7 times the size of Massachusetts. And I don't remember exactly Michael's number, but I think it was something like 10 to 12 a year. And I would have expected we'd be at 70 to 100 a year. And here we are in June, and we've had 3. And while you were talking, I Googled, and I didn't ask Kerry when he was here, but Adventist Health agrees to acquire California Central Coast, and UC Irvine acquired 4 hospitals. Are you surprised by 3? And are these kinds of things that I'm looking at transactions that should have been subject to a CMIR, or were they sort of prior to January 1st and therefore not? Or can you help me at all understand?
Sure.
How to think about the fact that we've only had 3 CMIRs.
Sure. Let me take your questions, split them up a little bit. Am I surprised? Yes and no. Okay. That would be, am I surprised about the fact that we've only had 3? Going back to you doing a quick Google search of some of these transactions. So remember that folks had to file the notices with us for transactions that closed on or after April 1st. We heard resoundingly how many entities were closing their transactions March 31st. In fact, we heard about entities working day and night to get done by the 31st. I reached out to some of these attorneys for these transactions that you just Googled and said, hey, if you need any help filing, please contact us. They got their transactions closed before March 31st. So that's why yes or no. So now that we are after April 1st, I think that, some of the volume that maybe we had anticipated, again, I was mentioning how layered and complex these transactions are. And remember that there are exemptions for notice to OCA when an entity has to file with the Department of Managed Healthcare, or when they have to file with the AG, or with CDI, or if it's a county acquiring a healthcare entity for continued access. So I think, I don't know, but I think that entities are looking at those exceptions and seeing where do they fall in terms of the notice requirement.
But also, Rick, you know, I mean, Sheila addresses into talking about the reg changes. The fact is our statute talks about healthcare entities. And so when, there are some shenanigans going on with private equity firms that are not, it's why we're adding the subject to language, because of the transaction. If a healthcare entity is the subject of the transaction, even if layers of limited corporations are being, and holding companies are being created, perhaps for multiple reasons, including or not, you know, evasion of this notice requirement, we do think this reg change is important.
Thank you. I'm so glad you added that, because that is another thing that we have seen where, you know, as I said, the entity whose assets or operations are being transferred isn't a party to the transaction, but it could be private equity working with the parent owner of that entity.
Okay. Anything else from the board? If not, Sheila, thank you for that, and we will take public comment on this item as well.
If you'd like to make comment, please step to the podium. If you're attending virtually, please raise your hand. Seeing no hands raised right now, we'll go to the podium.
Hello, Ben Johnson with the California Hospital Association. I just want to thank the office for this opportunity to provide comment on the revisions to the regulations. Support and thank the changes related to the confidentiality provisions, as that'll improve trust in the process. We do find that the changes to include and define subject of transactions somewhat ambiguous and overly broad, and we request a fairly minor change in the definition to address that issue. We understand other commenters have raised concerns about including the spending target and whether or not an entity is expected to miss it in the criteria that OCA considers in conducting a cost and market impact review. Just would note that should align with the enforcement date of when spending targets go into effect. And then, given the revisions to those provisions, would ask the office, consistent with, I think, statute, to also consider benefits of a transaction when determining whether to conduct a CMIR. And finally, to change the language in those criteria to make it more consistent with statute, such as if a transaction is likely to have a given effect, not may have a given effect. Thank you.
Thank you. Looking virtually, Janice, go ahead.
Thank you. Janice Rocco on behalf of the California Medical Association. 2 comments. The first one more process and the second one more substantive to do with the draft regulations. The statute does require the proposed regulations to come before the board, which is very helpful. And it's also helpful if a comment deadline isn't set prior to the initial board discussion, so that we make sure we understand the goals of the proposed changes to the regulations. But we did meet the comment deadline, and in the future, it would be helpful if those comments would be shared with the board directly, rather than having the attorney who's presenting sort of give a very brief summary and explain why those concerns are not warranted. In terms of one of the substantive comments in the letter from CMA, we did point out that, as was just acknowledged, that a subject of language being added is in part related to trying to pull in private equity transactions. It sounded like that was the primary motivation from what the director just said. And from a substantive standpoint, we are just looking at the fact that the CMIR process is currently being used only for things where nobody else has jurisdiction for approval or disapproval. And since there's pending legislation, AB 3129, that we're supporting, that would give the Attorney General's office authority to approve or disapprove such transactions, we don't want duplicative authority. And since you've got emergency rulemaking authority and you could do this at any time, we'd rather wait until we know the outcome of that legislation before you go down this path. Thank you.
Thank you. Back to the podium.
Beth Capel on behalf of Health Access California. We appreciate the desire to have input to the board prior to the board hearing possible regulations, but it would also be good to have the opportunity to provide formal comment after the board discussion. And I think there's a way to accommodate both in the process. The reason there's the 2-meeting rule is something we learned at Covered California. Discuss it first, take action a month later, and you avoid a lot of grief. With respect to private equity, we wholeheartedly support the change that has been proposed to add subject to make sure we capture transactions. We continually worry that small changes that would appear to be non-existent loopholes will be large enough to drive entire transactions through. We are co-sponsors of the measure that is pending today as I speak in front of the Senate Health Committee, and it is not yet on the governor's desk, much less signed, much less in effect. And as with all legislation, is subject to change during the process. So until that law is in effect and all these questions are resolved, we support OCA having the authority it should have to review transactions involving healthcare entities as was intended in the statute. Thank you.
Thank you. Looking virtually, seeing no hands raised at this time, noting we have about 75 virtual attendees looking to the podium. Seeing no one, that concludes public comment on this item.
Great. Thank you, Sheila. Appreciate it. Want to take a little break? Let's take a break. Let's take a 10-minute break, just to stretch and do whatever, and then we'll come back and do primary care. Okay, we're going to get an update now on our primary care definition and benchmarks, and we're going to give it back to the star of the day, Margarita.
Thank you. So, yes, for this next part of the meeting, I'll summarize the feedback we received from the board and public comments on the proposed primary care definition and our recommended primary care investment benchmark. And again, joining me today is Mary Jo Condon from the Friedman Healthcare team, who can help answer questions from the board. So our main follow-up items today, based on our board discussion last month, are focusing on the proposed primary care provider definition, including the rationale for OCA's decisions to exclude OBGYN and behavioral health providers, and then we'll review OCA's recommended primary care investment benchmark, and then we'll also spend time discussing the rationale for a combined benchmark for adults and children and the anticipated pace of change underlying the benchmark. We're not proposing any changes to the proposed definition or recommendation today. We wanted to share additional information with you all for discussion and can make revisions before coming back to the board in August. So just again, as we did with APMs, just wanted to share with you all a bit of background about our work with the investment and payment work group. So we've collaborated with the work group as we've developed our primary care definition proposal and benchmark recommendations. And we've been meeting monthly with the work group since June of 2023. And we focused on primary care mostly since last November. And we also convened a technical subgroup of the work group to really dive into the detailed work of developing the primary care definition. And so we received input from the work group on the definition, measurement approach, and benchmark, and also from the advisory committee, you all, and through public comment. And so the work group members have helped us incorporate this feedback and refine these recommendations along the way. So we will discuss the feedback and additional information from today's meeting with the work group in July, and then present a benchmark recommendation for your approval in August. So in this next portion of the presentation, again, I'll review the primary care spending definitions and measurement methodology and the feedback we've received on those areas. And then also provide more detail about our definition and welcome discussion on the definition. So to start with the board feedback on the definition, we heard last month there are kind of two general themes. There was concern about the exclusion of OBGYN providers, and we've, in our work so far and both through public comment and the work group, most stakeholders have preferred an exclusion of OBGYNs as primary care providers in our definition, and we'll go into more detail in a few minutes about that feedback and the approach. And the second theme was regarding behavioral health. So specifically wanting to ensure that behavioral health was captured as part of the vision for whole person primary care. And here we are looking to both define behavioral health services provided in primary care and behavioral health services. So we separately will be setting a benchmark for behavioral health investment, and that is the next part of our work in the investment and payment work group. And for the primary care definition, we are proposing that behavioral health services performed by a primary care provider in a primary care setting will be captured as part of primary care spending. And we'll talk a little bit in more detail about that as well. So the public comments on our proposed primary care definition and measurement approach were generally supportive of the proposed approach. Several commenters endorsed the proposed definitions for primary care services, places of services, and provider types, with the focus on holistic, person-centered care. There was also support for our use of the expanded framework to define non-claim spending and identify non-claim spending that counts towards primary care spend. And then we did see differences of opinion in the matter of excluding OBGYNs as primary care providers, with 5 commenters supporting the decision to exclude and 3 opposing it. So to start, or to kind of dive into the details a little bit more, I wanted to share our high-level kind of approach to defining claims-based primary care spend in these next few slides, and a summary of our non-claims approach, which we also reviewed in May. So this slide outlines our approach developed with the Department of Managed Healthcare and with input from the Investment and Payment Work Group to add nuance to our identification of primary care spending. So here, if you start at the top of the flow chart, in defining primary care spending, payers would identify claims with a primary care provider taxonomy as identified by OCA. And if the primary care provider taxonomy is a physician, a nurse practitioner, or a physician assistant, then the payer confirms that the provider is included as a PCP in their DMHC annual network report for those payers who are regulated by DMHC. So for example, an internal medicine physician who is not identified as a PCP in the payer's annual network report would be excluded at this step, and any spend associated with that internal medicine physician would be excluded. If the provider is identified as a PCP, or if the primary care taxonomy is not one that's tracked as part of the DMHC annual network report, the payer then moves on to confirm that the place of service and the service are both included in the primary care definition. So this allows us to be more nuanced and narrow in terms of who the payers are identifying as primary care providers and those who have actively chosen to be primary care providers in a payer's network. So in terms of provider taxonomies included as primary care, as we discussed last month, we're taking essentially kind of a 3-pronged approach for claims-based primary care spending. So is it a primary care provider who provided a primary care service in a primary care place of service? So these are the providers that we're proposing to include in that definition. And it's focused on providers who provide whole person continuous coordinated care. And to support the concept of care teams, we are proposing to include providers such as nurses and pharmacists in the definition, even though these are less likely to be sources of claims-based billing. So As we've discussed in the past, taxonomies do not always reflect a provider's current practice, and that is why we are using the approach of also filtering by the service and the place of service, and making sure a physician provider is also on a primary care list in the DMHC annual network report. And then moving on to services included as primary care. So OCA is proposing to include a broad set of services, including many identified by DHCS recently for the targeted rate increases to promote comprehensive primary care and primary care providers working at the top of their license. And then moving on to care settings. So here for care settings, we are requiring, as I mentioned, that three-pronged approach in terms of setting, service, and provider. And this provides the settings we're including as primary care settings. So the sites included here are traditional primary care locations as well as home and community-based sites. However, we have excluded retail and urgent care clinics, mostly because they do not typically provide coordinated comprehensive primary care. And again, this slide provides a high-level overview of OCA's proposal for measuring primary care investment paid through non-claims using the expanded framework categories that we reviewed earlier with the APM section. So I won't review this slide in detail since we reviewed it in May and just went through the expanded framework, but wanted to include it to provide that comprehensive look at both claims and non-claims in terms of primary care measurement. And also the proposed approaches in more detail are in your appendix. So digging into more detail in terms of the feedback we heard from the board and from our public comments on OBGYNs. So, as we've noted, our proposed definition does not include OBGYN practitioners as primary care providers, and therefore also excludes the services that those OBGYNs provided. The definition, however, does include a limited set of OBGYN services delivered by a primary care provider, and some stakeholders have commented that since OBGYNs typically do not provide continuous whole person care for all body systems, they should be excluded as primary care providers. Others, alternatively, have noted that OBGYNs do provide comprehensive care and expressed concerns about the discordance between statutory guarantees of access to OBGYNs and OCA's primary care definition, as well as the inconsistency of including reproductive health services when provided by PCPs, but not OBGYNs. And we note that ultimately in data that we have or don't have, evidence is lacking as to assess whether OBGYNs typically carry out all of the responsibilities as a primary care provider in terms of providing longitudinal whole person comprehensive care for all for conditions. And we wanted to stress also that OCA's primary care spending definition does not in any way change a consumer's right to choose an OBGYN as their primary care provider. And here we note we also recommend using the state's healthcare payments database, or HPD, to over time better understand the portion of OBGYNs who are providing primary care consistent with the services and the sites and the settings of service that we have proposed in our primary care definition. So in this next few slides, we'll just kind of lay out some considerations for including or excluding OBGYNs in the primary care definition. And either approach has implications for either overcounting or undercounting primary care spend. So OCA's proposed definition does not restrict based on diagnosis that's on a claim. So therefore, if OBGYNs were included as primary care providers, all services that they provide are defined as primary care. So for example, OBGYNs provide office visits for a wide range of patient needs, some of which could be considered primary care, but many of which could be considered specialty care. and all of those visits, regardless of the patient need or diagnosis, would be counted as primary care. So this would result in an inflated primary care spend figure. On the other hand, excluding OBGYNs means that preventive screening, contraceptive and prenatal care, and other primary care services they provide wouldn't be included, and this leads to undercounting of primary care. So we note that carving out specialty services by creating a separate definition for OBGYNs for both claims and non-claim spending might be a best balance or a best approach. And we've determined that this approach would be overly burdensome on data submitters and quite complex to implement. So this leaves two considerations. So the first is the current proposal is to include a limited set of OBGYN services when provided by a primary care provider and exclude all services provided by OBGYNs, and that OCA would use the Healthcare Payments Data Program to analyze the impact of this exclusion. And again, the trade-off here is that it underestimates primary care spend. And another option would be to include OBGYNs who are designated as primary care providers in the DMHC regulated plan networks when they provide a primary care service at a primary care place of service. And this would count all OBGYN office visits as primary care, even when they may be for a specialty diagnosis. And so this would overestimate primary care. And we've just provided a few public comment examples for your reference on this slide as well. And then next we'll turn to behavioral health providers, and then one more note on future analysis, and then open up for discussion. So we also heard from board members that had questions about OCA's approach to behavioral health services delivered in primary care. So OCA's primary care definition captures a limited set of behavioral health services delivered by primary care providers in a primary care setting, and it also captures payments to support integrated behavioral health. And then separately, as we've talked about a few times today, as part of the work beginning in the investment and payment work group next month, we will develop an approach to measuring behavioral health spending more broadly and setting a behavioral health investment benchmark as required by statute. And this spending benchmark would look at all other primary behavioral health that is not provided in a primary care setting and a broader set of services. So looking at the other states' primary care definitions, 9 of the 15 reviewed exclude behavioral health providers, and only one state includes behavioral health providers in its primary care definition and also measures behavioral health spending separately. And in terms of some additional analysis that the office could conduct in relation to its primary care definition, these are some of the analyses that the work group suggested that we could supplement and add context to the data that is gathered from payers on primary care investment. So we will pursue these analyses using HBD data as feasible. So some examples include tracking primary care services provided by OBGYNs using our current definition or with a modified list of primary care services. And wanted to note here that recent estimates from the Integrated Healthcare Association, IHA, and other states suggest that this would be less than 0.5% of total medical expense. We also heard interest in measuring the proportion of OBGYNs providing primary care consistent with the work group's vision. Heard suggestions for monitoring primary care spending if not restricted by service or place of service. So this could be looking at primary care services provided in retail clinics, and also in this last set of spending on primary care services delivered at retail clinics and urgent care sites. And estimates from spending in other states and IHA found that primary care spending at these sites may have a minimal impact of approximately 0.2%. So wanted to pause for discussion and questions from the board and any additional feedback on the proposed primary care definition.
Any questions from the board? So, go ahead, David.
Well, again, Margareta, thank you for the great work and the great presentation. I'm kind of uncertain about how I feel about the OBGYN question. I'm noting that that 5 letters versus 3 letters is kind of a 1 degree of freedom away from being split on the topic. But actually, more concerning to me is I think the recommendation or the thought that additional analyses should be performed is a good way to proceed, because I myself have good empiric data about the role of OBGYNs in primary care. My sense as a practitioner is that there is a slice of the primary care pie that is actually provided by OBGYN individuals, physicians, especially for patients that have no other healthcare problems. They may be receiving primary care from that specialty. I recognize that we're talking about covered entities and the assignment of somebody to a primary care panel. That may be a different thing than services actually rendered. I note there's a contrast between the position for OBGYNs and maybe pediatricians. I think we're making a recommendation that pediatricians be globally included as primary care providers, but recognizing also that in pediatrics you have pediatric oncologists, you have pediatric cardiologists, you have pediatric infectious disease doctors who are probably not providing primary care, but their services could be considered primary care under the construct. So I think that maybe this is something that is a topic that we'll want to continue to consider as we go forward with the process, knowing that the data here are not necessarily as complete as they could be.
Margaret or Mary Jo, can you address that? I mean, is a pediatric oncologist included under as a primary care provider?
Make it green.
Now it is. So having that additional step, we're essentially requiring the individual to be listed as a primary care provider with the Department of Managed Healthcare, I think is an important step to ensure that exactly what you just mentioned does not occur.
Marguerite, so on your slide 126, this is on the behavioral health piece of this conversation. 9 of the 15 states did not include behavioral health. I'm curious, what did the others do?
Sure. So they did not, so 9 of the 15 did not include behavioral health providers. 6 did. However, only one of those 6 states has a separate mechanism to measure behavioral health care spending at all. And so essentially, in those 5 states that chose to include behavioral health care providers in their measurement of primary care spending, in those states, they have no other mechanism to measure behavioral health spending. And so that's sort of different from California, which has this other mechanism to measure behavioral health spending, which we're going to start work on soon. And so essentially the thinking here was that we would have a module within the primary care definition that would be specific to behavioral health services provided by primary care providers in a primary care setting. And then essentially whatever that spend is, let's just say it's $5, just for an example's sake. That $5 could either be added to the primary care spending analysis or to the behavioral health spending analysis, because they're really both. They're primary care spending and it's behavioral health spending. And so we essentially wanted a way to isolate those dollars and then include behavioral health services provided by behavioral health providers in the behavioral health measurement work stream, which gets underway this month.
So I appreciate that. And I appreciate that we haven't done the behavioral health work yet. I do think it's super important to recognize that I think as we contemplate whole person care in a primary care setting, that integrating behavioral health is critical to that. So as long as that is the tenet as we go into planning for behavioral health, that is really important because we have a long history of keeping all the behavioral health, psychiatric care, mental health care in a separate and unequal delivery system, and that is certainly not something we want to perpetuate or continue. And so just so we are all on the same page around that, I assume that our thinking is consistent with that.
That's exactly right. And in fact, most integrated behavioral health is paid separately through non-claims payments, not all, but a lot of it. And those integrated behavioral health payments paid through non-claims are included in the primary care definition. So those would also be included as primary care spending in that behavioral health primary care module.
Okay, great, super, thank you. Marguerite, and then just a question on the types of positions that we are considering for primary care spend. I noted that community health workers are not listed in that space. How do we think about that in terms of advanced primary care practice and do you have a way to capture those workers as part of the team?
Can we go back to that slide for a second, Margaretta? Yes. So you'll see here that we do have several different members of the care team. I believe that the issue here was that community health workers did not have a defined taxonomy, and I can confirm that. But Margaret, is that also your recollection?
That's my understanding as well. And so focusing here on for the claims-based spending, focusing on providers that have a taxonomy that we can identify on a claim in terms of how we define claims-based primary care spending, but that any care in terms of the team would be included in the non-claims spending that we measure through non-claims primary care spending that we also measure. So would definitely include care provided or services provided by a community health worker in the non-claims spending. And we can go double check as to whether community health workers and if there are other types of providers that have a taxonomy that we could make sure that they are included on our taxonomy list, if that's the recommendation to include additional providers who may be part of the primary care team.
Yeah, I mean, I think taking, again, a very comprehensive view of who's on a primary care team, so that might be a nutritionist, it might be a pharmacist, might be a health worker, might be a promotora. I just think it's important for us to appreciate the complexity of what we'd like to see in a comprehensive primary care home and team. So, and I'm sorry Mark's not here, but in Medi-Cal now, the plans can bill for CHWs. And so I don't know if there's a taxonomy associated with that, but I encourage us not to, especially because that particular subset of the workforce tends to be more culturally and linguistically prepared than the rest of our workforce. Super important that we not leave them off. And maybe there's work to be done to create a taxonomy there. I know CHCF has an interest in that as well, but I just didn't want to lose that notion that this is not a comprehensive list of what we would consider to be a primary care team member.
Yes, and one other point just to for clarification on page 121. I'm not very familiar with the POS codes, but wanted to make sure that there were 2 delivery environments that were actually included in the POS codes. And so, for example, the first example is the county public outpatient centers, these comprehensive care centers. They might be considered an office, but they're really much more than a traditional office. And they provide a lot of primary care within the LA County healthcare system. The other would be a question about where would the Kaiser Permanente comprehensive outpatient centers fit? Are they part of the office code or are they something different?
Thanks, David. I think we'll have to go back and look at that and double check and make sure that we've how their place of service is identified and to make sure that it's included as one of these. So it's the county outpatient clinics or outpatient?
Usually called centers.
Centers, okay. For both Kaiser and counties? Okay.
Yes.
We'll take that back.
Great. Anything else from anybody on the board? Okay. Yeah, John, please. Push your button, please. John.
I'm wondering about providers that are essentially providing primary care, but in alternative settings, and that's not alternative used in the way that we've been using it today, but virtually, for example, when it's envisioned not as a part of a care team, but more episodic, and also similarly maybe primary care services provided in an urgent care clinic, for example, and how, and maybe it looks like you maybe hit on this and I missed it, but.
So, and again, Mary Jo, please correct me if I'm wrong, but a primary care services provided via telehealth setting or remote patient monitoring or any of the e-consult type services would be included in our primary care services definition. However, if the primary care service was provided at an urgent care site or a retail clinic, we are proposing to exclude that spending from our primary care spending definition.
Yeah.
And this was based on lots of work group discussion in terms of focusing the primary care definition on what is kind of the vision we want for future primary care, and the work group was really interested in making sure that those types of primary care services are provided in a more either traditional or virtual primary care setting, so that folks have greater access to their primary care providers, in a continuous way.
Yeah, so not suggesting you go back and rethink any of this, but just food for thought, because we struggled with this a little bit in the development of the PPO we're moving forward with, where we supplement primary care with a virtual primary care network, recognizing that in some parts of the state, people don't have access to primary care when they need it. And in those instances, we don't envision that particular type of primary care is what we want people to have on a permanent basis. It is what we want. So it's sort of an urgent, it's a more of an urgent need thing. It's virtual, so it's supplementary. We're contemplating using the virtual behavioral health network differently because we have lots of evidence that it works pretty well, but mixed reviews on primary care. So just as we think about that and the different uses of virtual care, I think some of them maybe fall into what you're thinking of when you're thinking of urgent care, and some of them do not.
I would clarify that the solution that you brought up and sort of third-party vendor solutions paid for by employers or other purchasers sort of outside of the payer claims-based environment would not be counted because the data is being submitted by the payer. And so if this is something that a purchaser is, purchasing on on a per member per month basis, let's say, or on a fee for service basis, but not through the payer or TPA, then it wouldn't be included.
Yeah, this would be through our. I mean, it's a joint venture, but it's essentially a TPA arrangement, and it's one half of the TPA arrangement. And I certainly have heard from conventional health plans, HMOs, that envision using some of this to supplement, in exactly the same kind of way that we envision using it.
Rick?
I saw the estimate that urgent care clinics are 0.2% of total primary care, and if that seems right, and I haven't looked at the report behind it, then it's small enough that I'll just be quiet. But if they are significantly larger than that, and/or if there is any thought that utilization might increase, then I think at least keeping track of that would be important over time. Maybe not including it in the benchmark. It's maybe not the care that, not continuous care, but if that's the way people are getting primary care services in any reasonable number, I think it'd be important to know about that. And I don't know whether it's feasible to ask payers to report two things. One is real primary care, and the other is not real primary care. But
I will share anecdotally to your concern that a couple of years ago we went up and met with Shasta County to talk about concerns they had with access up there, and the initial reason for the meeting was that nobody could get into urgent care, and when we unpacked, it was because nobody could get into primary care, and everybody was going to urgent care to meet their primary care needs, such that urgent care was full. So again, anecdotally, but there's at least one example of a not a small county where you're seeing that kind of behavior, and I mean, I'm sure it happens other places.
I think there's no question it happens other places, because most primary care physicians are not taking new patients. That's true,
right,
pretty uniformly in across the state in different areas, and particularly so in rural areas. So if you don't want to go to an ER, and urgent care is really your only choice.
Right.
It does not make the criteria for continuous primary care full scope, but it is creating an access opportunity in some places.
Yeah.
Could I just interject on this? I'm not making the case to include urgent care, but it certainly is a geographic issue, but it's also in terms of populations, those who are unable to take time off work during business hours are going to urgent cares in lieu of primary care practices as well.
Thank you. And yes, we did hear several recommendations from our work group to track primary care services provided in urgent or retail settings. So we are looking in and have started conversations with the HVD team in terms of how we could do that to try to better understand the amount of primary care services being delivered in those settings and track that over time as complementary to our primary care investment measurement. And I'll just note that again, going back to kind of the work group's emphasis on basing the primary care definition on our future vision of primary care and how we want to see primary care delivered and where we want to invest. And so that really guided a lot of our decisions in terms of inclusions or exclusions of settings.
Okay, if there's nothing else from the board, we will go to public comment, please.
Sorry, Sandra, we have one more section on the investment benchmark and follow-up questions about the investment benchmark. Please. Sorry. And then we'll go to public comment. So again, in terms of the investment benchmark, we heard from the board, several themes in terms of feedback on our investment benchmark. The first was we heard from the board that they're interested and wanted to see faster progress in early years of the benchmark implementation. The benefit being that more dollars going sooner to fund infrastructure development and workflow redesign and primary care generally, and wanted to note that there are trade-offs in terms of balancing early investment versus long-term investment. Note that it takes time for providers to shift care delivery practices, and some may not be ready to use, make full use of the increased investment. And note that research finds generally that the full benefits of increased investment often do not occur immediately, and payers will be balancing these increases with efforts to slow growth in total spending. Next, we discussed the possibility of creating separate goals for pediatric and adult populations. And OCA has determined that the data submitter burden associated with two benchmarks likely outweighs the benefits, especially when it comes to allocating non-claim spending. And allocating non-claims payments by age group would also require more estimating and additional assumptions beyond required for a single benchmark. So the current plan is to collect and report on claims-based primary care spending by age group, but the benchmark will span all ages. We also heard an interest in collecting data at the medical group level. So OCA does plan to collect and report data from payers at the medical group level. And we are also planning to collect data from restricted or limited Knox-Keene licensees in the future, but OCA has not determined whether it will collect data from additional entities in the future. There was also an interest in understanding how OCA's proposed definition compares to the Integrated Healthcare Association, especially as that is the data we are using in terms of current primary care investment, and how those differences might affect the benchmark. And also looked for, we heard an interest in looking for more information about the predictors of success of increasing primary care investment based on other states' experience. So we'll walk through these responses to these and provide more information. And then in terms of public comments were generally supportive of the current approach to the benchmark. There was support for the 15% benchmark and the annual improvement benchmark of 0.5 to 1% per year. There was some concern that achieving the benchmark in 10 years might be unrealistic. And then we also heard a bit on the other side that 10 years may be too long, and heard that from the board as well. And then wanted to note that we feel that the 10-year timeline aims to strike the balance between feasibility and urgency, especially with the requirement of an annual improvement. And public comments were also in support of a single benchmark for all ages. So we heard a request for more information kind of on the other states' experience and how they got to where they are in terms of their primary care investment last month. So wanted to share this more detailed information on a slide you have seen before, and talk more about the states in this graph. So we'll walk through these. So in terms of Colorado, here their focus has shifted a bit from primary care investment to really focusing on APM adoption, which may be leading a bit to their kind of steady state in primary care investment. Delaware's progress has been prompted by statutory requirements for minimum fee-for-service payments equal to Medicare rates and increases in overall investment, as well as increases in primary care non-claims payments. Oregon's Patient-Centered Medical Home Initiative, or PCMH initiative, increased primary care spending in that state. Oregon also has a lower total cost of care than many other states, a broader definition of primary care, and excludes pharmacy from the total cost of care denominator, all of which increase their primary care spend percent. And then Rhode Island here slowed total spending with price growth limits while primary care spending increased. And it's also benefited from robust care transformation initiatives. And there was a request for more information on the Rhode Island experience, so we've included a link to that study in this slide. And then lastly, Connecticut has faced some challenges in terms of increasing primary care investment as total medical expenses have outpaced their increases in primary care. So again, here just wanted to share these few slides on both the California experience and current understanding of primary care spending. So this is, again, you've seen this slide for the Medi-Cal primary care investment. So this study showed an average of 11.3% of spending on primary care services in 2018. And just wanted to note here that the Medi-Cal report used a different data source and methodology than OCA is proposing. The report used Medi-Cal rate development templates as a data source, which is quite different than OCA's data collection process. So we expect the percent investment calculated by OCA will be lower than calculated using this methodology in this study. And then again, you may also remember this slide from last month. It shows data from the Integrated Healthcare Association on spending, primary care spending in California for different markets, and the combined commercial spending and Medicare spending are similar, both hitting the neighborhood of around 10% in 2021. And then the request to provide more details about the differences between the OCA and IHA primary care definitions are outlined on this slide. So, want to emphasize that the two definitions are largely similar. So we both use provider taxonomies to define primary care providers. The note here is that OCA will also require the providers to be designated as primary care providers in the DMHC annual network reports. Both definitions include a broad list of providers when a primary care provider performs them. OCA's list is the broadest of any state's definition. However, IHA did not restrict by service. And then both definitions include a wide range of settings, with OCA including a few places of services not aligned, OCA excluding a few places of services not aligned with our vision of comprehensive coordinated care. And then both definitions include the most common types of non-claims payments, capitation and incentive payments. However, using our expanded framework and additional data collection, we will be able to capture other types of non-claims payments, so care management fees, infrastructure payments, and any portion of shared saving payments that are paid to primary care providers. So we expect that this will have a slightly higher effect than the IHA definition. We don't know the exact impact of the differences in these definitions, but we estimate that the OCA results will likely be 1 to 2% points lower than if measured under IHA's definition. And then a few more slides just to wrap up. Wanted to emphasize the challenges we see in separating non-claims payments by age group, and how this interacts with our recommendation to have a single benchmark but track claims-based primary care spend by age group. And generally, non-claims payments are not tied to a specific service, provider, or patient, and they're not usually segmented by patient age group, so it can be challenging to separate them out. For example, a shared savings payout to a provider group for care delivered to its entire population, there would need to be a variety of assumptions made to split that out by age group. And this would create additional administrative burden and complexity in our data submission process. So to wrap up, this is the proposed primary care, our draft primary care investment benchmark recommendation. Again, as we noted earlier, we will come back to present this recommendation for adoption in August, and wanted to get, again, any feedback you all have on this recommendation. So Here, the approach combines an annual improvement benchmark of 0.5 to 1% each year for payers with a statewide investment benchmark of 15%. And the annual improvement benchmark we think is really critical, especially for those payers who are currently spending in the low range of the primary care investment range we see. So, we see from 4% in some PPOs to less than 7% in some HMOs. So this annual improvement benchmark offers an opportunity for payers to demonstrate immediate progress reaching towards that 15% goal. And the 15% goal is quite ambitious. It's higher than any other state today, but we think it's achievable, especially with the 10-year time frame. And note, as we discussed a little bit earlier, that the longer time horizon is important based on the need to reallocate spending to shift the delivery system in terms of how we're delivering primary care to increase access to primary care settings. So the 10-year timeline recognizes the need for that change and also provides time for changes in the primary care workforce. And both of these measures are constructed with some flexibility. So, we will measure initially and have a baseline, and based on that baseline, a payer will know how much they have to improve over the 10 years to meet the 15% benchmark. So we'll wrap up here and open up for discussion and questions.
Members of the board, comments? Rick?
Thank you again, Margareta, and thanks for the explanation about the rationale for not having separate adult and child benchmarks, which for statewide certainly seems fine. I would remain concerned that, if this ever gets used to compare how Medicare Advantage plans are doing compared to, say, Medi-Cal plans, where the patients, the age distribution of the patients is so different that we need to be very careful in not doing straightforward comparisons, but doing some kind of age adjustment there. I appreciate your explanation that allocating non-claims-based payments would require some assumptions. We've got assumptions throughout this process of doing THCE, and this would not be the most heroic set of assumptions, I think, that we've been engaging in. I think that's a probably solvable problem.
Other comments? I don't really have anything to add. I think it's an ambitious goal. I think we heard from Blue Shield today, they're in single digits, and this is a health plan that has leaned very aggressively into advanced primary care. So we have a lot of work to do, but thank you. Okay, barring anything else from the board, I do think now we'll go to open public comment.
We'll move to public comment. If you're in the room, please step to the podium. If you're online, please raise your hand. And at this point, we will combine public comment on this last agenda item and also general public comment. So inviting both. Seeing no hands raised, we will go to the podium. Thank you.
Beth Capel for Health Access California. Do you appreciate the Dr. Hernandez's suggestion on community health workers, which some of us have been working on it for a long time, but actually in some respects it's still an emerging concept, and to acknowledge there will probably be other emerging concepts over the next decade. On OBGYNs, we have shared our view in the past that if an OBGYN is who screens for asthma, diabetes, depression, and high blood pressure and treats those conditions as well as the other conditions women have and other persons, we would regard them as a primary care provider. We do recognize that in some instances, women rely on OBGYNs, but they don't necessarily provide that whole range of services. And as Margareta has said, and we have said again and again in the work group setting, we're moving to a vision of primary care that's designed to anchor and move us to lower cost care with better results for people. And every well-functioning health system we've reviewed does that. With respect to urgent care, I would commend to you the practice of the Netherlands, where all primary care practitioners are required to provide urgent care one night a week. This was, by the way, a favorite concept for parents of young children when presented in the legislative committee. Thank you.
Thank you. Looking online, Harvey, go ahead. Harvey, we can't hear you yet. You're unmuted on our end.
You should be able to. Is that better?
Yes, we can hear you.
Okay. Yeah, Harvey McKeown, Carpenters Union. Thank you very much for bearing with my earlier technical difficulties. In some ways, a blessing in disguise, as I think my comments perhaps are more appropriate for general public comment in any case. But, you know, we are an organization that represents workers that often build hospitals and healthcare related facilities. And that has now been engaged with OCA on other topics. So in that context, it would be remiss to not at least express a general hope or wish that at some point, whether at OCA or another appropriate HCI related board, that the workforce stability conversation we are having ends up extending to an even broader universe of workers that hold up our healthcare system in vital ways. For the purposes of our organization, this of course includes the 11 apprenticeable crafts we represent and the extent to which they comprise any given healthcare related construction project. To be clear, we are advocates of preserving and advancing responsible contracting practices in healthcare related construction. This results in safer buildings for patients and healthcare workers, especially insofar as legal requirements such as seismic retrofitting and other complex construction delivery is concerned. Admittedly, this is not the direct topic of today's discussion, but I think this topic does connect to OCA's overarching mission of ensuring healthcare is high quality. Access is also indirectly implicated here, since responsible contractors are more likely to provide health benefits for workers themselves, and currently construction worker families are disproportionately reliant on medical safety net programs in California at a great public cost. So I just wanted to really just go on record with saying this, although I do appreciate this is outside the remit of today's workforce stability discussion, and I appreciate the complexity and the priorities of the current issue at hand. I enjoyed the presentation on workforce stability and others, and I thank the OCA board as always for all its work. Thank you.
Thank you. Looking to the room, seeing no one at the podium, we will move to Janice. Go ahead.
Thank you. Janice Rocco with the California Medical Association. On this item, I think there's a lot of important and good work that has gone into it, and I think we're headed in a good direction. The one topic I did want to go back to, however, is the staff recommendation to exclude all primary care that's provided by OBGYNs from the definition of primary care spending. At last month's board meeting, we heard from board member after board member who disagreed with that proposal, as well as at least 4 provider groups and plans that oppose it as well. And the staff were asked to rework the proposal. And I do think that before the next board meeting, it would be helpful if the staff reached out to those organizations that have providers and to the plans that have been opposing this proposal for months now. And talk with us about how to make this work, because the board members were uniform last month in wanting to not have a situation where all primary care provided by OBGYNs was excluded from the primary care spending calculation. And we don't know right now what that spending calculation is going to be used for in the future. But if we exclude a lot of the care that's provided to women in this state, we're probably going to end up with some discriminatory outcomes. And that's very worrisome. I will say that as I've talked to our members of various primary care or specialists, all of them have said to me, of course, we need to include the primary care that OBGYNs are providing. And as I've talked to patients Woman after woman has told me that at some point in their lives, and many of them currently, the only care they receive is from their OBGYN. So it's not an incidental issue. So I would like that the staff would work with those of us who agree with the board members who were very clear last month that they did not agree with this proposal and to come up with a different one for the next board meeting. Thank you.
Thank you. Looking back to the room, to the podium.
Thank you. Marissa Montano with the California Academy of Family Physicians. As we previously stated, CFP is mostly supportive of the narrow primary care definition that meets the goal of setting comprehensive, coordinated system of care that saves money and improves healthcare outcomes. In the context of this goal, we do believe, especially given that we need to see more of the evidence to show that OBGYNs are managing care across body systems, that without that evidence, we should probably exclude this specialty. But if there's additional analyses done and more data becomes available, we would be supportive of revisiting, and we should make those adjustments to the primary care definition. CFP is also supportive and applauds the setting an ambitious benchmark to achieve the primary care investment benchmark, although notably if data and evidence shows that we can move faster on those goals, we would also be supportive of that. Thank you.
Thank you. Looking virtually, seeing no hands raised, we'll give it a moment. Anyone in the room like to make a comment, please step to the podium. Seeing no virtual hands, noting for the record, we have about 60 virtual attendees. Seeing no one at the podium, that concludes public comment.
Great. Let me thank staff for a tremendous amount of work in preparation of this meeting. I hope you have a nice July off. And we'll see everybody in Monterey in August. This meeting's adjourned.